Hello everyone, how are you today? Um, um, Today actually it will be a long session, a little bit. I will explain the remaining of the obstetrics together with most of the pediatrics. We will be left with 4 or 5 pediatric stations, which will be discussed tomorrow, inshallah. They are short stations anyway. They are new but short stations, um, but they will barely take us maybe 1 hour tomorrow, inshallah. Um, just give me one moment. Okay, so um, today I hope we'll be fast a little bit. That's why I advised all of you to read the pediatric stations. Um, Today, actually, I'm sorry, but today, uh, no many pauses or no many interruptions are allowed because today we have to cover at least 19 stations. We are almost close to the finishing time. So if we keep discussing each and everything, we will never finish anything. So please, we try to be fast here today. I'll be giving a break in the middle, short break. That's why we need to be fast today. Okay, and generally, if there's something which is hard, I'm going to elaborate it or I'm going to stress on it more than one time. So please try to concentrate for today and try to give your best. I'm sure that all of you, maybe some people are having some other work or some other duties while listening. Uh, if you're doing any duty, I'm sorry, but interruptions are not allowed today because seriously, we have to finish many things. Um I mean, it's not my fault. I think it's just because there are more than 240 stations, and no course will cover all of them for you. So just I'm trying my best to cover all of them. Okay. So let's start with today's stations. Yesterday we stopped at the cystectomy, the dermoid cyst. Today we are going to start, or we are going to resume the OBG station, the remaining ones. Just give me one moment. Okay. So we will start today with the gonorrhea station. Here the task says that your FY2 work in the OBG department, the girl or the woman has come for sexual health checkup, routine checkup. The STI screening shows that she's having Neisseria gonorrhea. So the STI screening here shows that she's having Neisseria gonorrhea. Here, actually, you have to disclose the test results to her and address her concern. Okay, it's definitely like the PID station. It is STI screening or STI station. So you'll be having to take the same history exactly. You will start the station by how can I help you? She told you that she has started the recent relationship and she told that she should come and check up on herself. Now, the task here, by the way, I forgot to tell you, the task tells you that you have to talk to her and take sexual history from her and address her concern. So this means that you should prioritize the sexual history here. You should take sexual history before anything in the station. So you will ask her, first of all, my voice is clear. Is there any interruption in my voice? Anyone could hear any interruption in my voice today? Okay. So you will tell her, or you'll ask her, do you have any partner? She will tell you, yes, doctor, I met my boyfriend recently. So it's a sexual history. Are you in stable or are you in a relationship or are you sexually active? Yes, doctor, I had a boyfriend or I started having a boyfriend recently. So may I know when did you start? It was like 3 weeks ago. So she started the recent relationship 3 weeks ago, and she most of the time she does not practice safe sex. And when was the last time she had unprotected sex? It was maybe 2 days ago. Any other partners? She will tell you, yes, doctor, I had partners, two other partners in the past, but not right now. Okay, so now everything is quite obvious. Everything is quite obvious that she's having she had unprotected sex in the past, and she started a recent relationship. So she could be two reasons for the STI or the gonorrhea here. Is that she started a recent relationship with unprotected sex, and she had also many relationships in the past, like 2 or 3 relationships in the past. Now we will take some. Now you finish the sexual history, but also you can ask her, do you have any symptoms right now? For example, like maybe any green discharge or any pain or any swelling anywhere in your body. She will tell you no, doctor. So you took medical like current complaint or presenting complaint. She doesn't have any complaint, but just you have to ask about the relevant condition, and you took sexual history. Now move to the past medical history. By the way, sometimes she can give you history of burning sensation while passing urine. So burning sensation while passing urine dysuria. Sometimes it can happen with STI. So what are the questions to ask about STI? Number one, any redness or swelling in your private part. Number two, any discharge. Number three, any hotness. Number four, any dysuria or any burning sensation while urine. Okay, now ask here about in the past medical history. We'll ask about the medical conditions. Have you ever had sexual transmitted infection before? No. No medication, no allergy, no family history, nothing at all. Here, one question to ask and not to miss in the family history is that your partner is having similar symptoms or not. You have to check the partner clinical picture as well, if he is showing similar complaints or not. Do not forget to ask about the lifestyle. Before the lifestyle, you have to ask about the 4 Ps. So here again, sexual history because it's a priority. Number two, complaint, like presenting complaint. Number three, past medical history. Number four, number four, 4 Ps, very important. When was your last menstrual period? Is it trigger any heavy or painful period or any heavy or painful bleeding? Do you use any method of contraception? Have you ever used the coil or IUCD? Okay, now our history is done. Again, the priority in any OBG station, priority is for the 4 Ps and the sexual health or sexual history. So do some examinations. Which examinations? Vitals, general physical examination, and abdominal, very important, together with perispeculum examination. Okay, here we do not do the bimanual. Why? Because it's just STI. But if you want to check for the complication, which is not present because she does not have any symptom already for the STI. Okay, so how come she can show complication? It just started maybe 2 or 3 weeks back. But if you want to do bimanual, okay, no problem. Now disclose the test results to her. What is the treatment or what is the problem, doctor? Tell me, please. Now you're going to tell her that from my assessment and from what you told me, it seems that you're having a condition we call sexual transmitted infection, which is the infection passed from one person to another through unprotected sex. And in your case, it has been caused by a bug called Neisseria gonorrhea. What is this, doctor? Is it dangerous? Now reassure her that this is a common condition and we know how to treat it. We have very effective medication for it. Now she will ask you, doctor, what are you going to do for me? So what you are going to do for her, number one, you're going to prescribe for her antibiotics. Please make sure that you ask about the allergy. You ask about the allergy in the history. Okay, so now you can give antibiotics. She will tell you, doctor, which antibiotics. Here, this is one of the very few stations in which she will ask you about which antibiotics. Okay, the medication for the STI or for the gonorrhea is single injection of ceftriaxone, 500 milligram IM. Single injection ceftriaxone, 500 milligram IM. And single dose of azithromycin, 1 gram per oral. Again, single injection ceftriaxone, 500 milligram IM, and single dose of azithromycin 1 gram per oral. This is the core of the treatment. Okay, what's next? Some advice. Remember the PID? Here also we have to give some advice. But here in the PID told her to not practice any sex for 2 weeks. But here you will tell her to abstain or refrain from any sexual activity for 1 week. 1 week from sexual activity, even if protected sex. She has to stay far away from sexual activity for 1 week. Okay, so and you will tell her that she needs to come to the hospital after 1 week. Why? Because we will do or we repeat the test for her. If the test comes back negative, she can resume her sexual activity. Now, here comes one important question in the management. She will ask you, doctor, how did I get it? You will tell her that it is usually through unprotected sex. So, doctor, you mean I got it from my boyfriend? Or from, she will ask you from him? Okay, at this point, it depends. There are 2 or 3 possibilities. Yet if she is practicing, if she is practicing unsafe sex with him right now, and she practiced safe sex in the past. So practice safe sex in the past, but practice unsafe sex right now. This means that she got it from the partner. So he's cheating to me. Now you can tell her that usually the STI can be present in our bodies for long without causing any symptoms, which means that he could have caught it from his previous relations as well. So he could have caught it from his previous relations, not necessarily right now. There is a second possibility that she is practicing safe sex with him right now, but she had unprotected sex in her past. So you will tell her that definitely, in this case, most probably you got it from your previous relationships. This is second possibility. Third possibility is that she is practicing safe sex. She is practicing unsafe sex with him right now, and she used to practice. There are 2 possibilities only. I'm sorry, I just mixed things. So 2 possibilities is that she is practicing safe sex with him and she is practicing unsafe sex with him. It depends on the sex. But in both cases, she will say that he is not cheating to her. Okay, okay. So now you told her that she should abstain from asexual activity, number one. Number two, the second advice is that you're going to give to her is that she should bring her husband for testing and treating. Remember, any STI you bring for testing and treating as well together with HIV. You will ask her that you may need to test for HIV or screen for HIV as well. And she is not reluctant to bring her partner. So he'll ask you one question, doctor, I'm on contraception pill. Is it possible to get infection when I'm in contraceptive pill? You will tell her simply that the pills do not protect against the STI. In order to be protected, you need to use a condom. So now one more question, what are the complications of gonorrhea, doctor? You will tell her that it can recur again and again. And if it's recurrent, still sometimes it can cause a condition we call PID. And now you can speak about the complications of the PID. For the girl. And for the male, the gonorrhea can cause some problems in the urination, some problems in the epididymis as well, which can ultimately lead to infertility. So this is the station so far. Wait, give me 1 minute, guys. Sorry. Excuse me, guys. I was muted for a minute, Dr. Yasmin. No worries. So we are done with the gonorrhea station. It is a very easy station, and I believe it's typically like the PID. Definitely like the PID. The only difference is that here she should abstain from sexual activity for 1 week, while the PID is 2 weeks. Why? Because the PID is definitely more dangerous. Number two, pre-eclampsia station. Okay, in the pre-eclampsia station, actually the task here tells you your FY2 working in ABG. Your FY2 working in OBG, and the patient is presented with for a sexual. Wait, I'm just confirming something. I'm just confirming the task again because I got this station, by the way, in my exam. I got 9 in it, though I didn't finish it because the simulator was not cooperative as at all. Okay, yes, you are working in OBG department. The patient is presented in the 30 or 36 or 38 weeks pregnancy, and she has been referred to the hospital. Um, and other information, the midwife has seen her and she measured her blood pressure. The blood pressure is 150 over 100. Urine test shows 3 positive protein, which means that there is protein in the urine and the blood pressure is high, and in 38 weeks of pregnancy. The patient blood pressure in the first reading was 110 over 70. So now you'll find that the blood pressure has risen from the first time to this time. First reading means when the first on the first booking, which means that the first antenatal visit. Um, okay, what you must do to the patient and discuss about further plan of management. So you'll ask her, how can I help you? She will tell you, I came for my checkup and I has been seen by a midwife. She asked me to come to the hospital because my blood pressure was high and there was something in my urine. Now remember, now we need to ask her, she's coming for the health checkup or for her pregnancy checkup, which is the antenatal checkup. We need to ask the pregnancy question, the pregnancy question from the introductory session, if you remember. Number one, can you confirm the age of your pregnancy? She will tell you either 38 or 36 weeks. Number two, how has your pregnancy been so far? She will tell you it's okay, doctor. You will ask her, have you had any problems like any complications? No, doctor. Have you attended all your antenatal clinics so far? She will tell you, yes, I had 5 antenatal appointments and I have attended all of them. So she attended all her antenatal visits and she has no complications when the pregnancy is fine and she's 36 weeks pregnant. Now ask her, is it a single pregnancy? Yes, doctor. Do you remember the blood pressure in your first reading? Why I need to ask this question? Because now I know there is a problem in her blood pressure from the task. So she will tell you, yes, doctor, it's 100 over 110 over 70. And how have you been pregnant before? She will tell you no. What if she tells you, yes, I was pregnant? You will tell her, when was that? How old are they? What was the outcome? Any complications? What was the method of delivery? The present, now you ask the obstetric history and ask her right now about her current health. How do you feel right now? She will tell you, I'm fine, doctor. Just the midwife asked me to come to the hospital. Do you have any symptoms? Like what, doctor? Do you have any tummy pain? No. Any visual problem? No. You mean the symptoms of hypertension? I'm going to ask you. Any tummy pain? Any visual problem? Any headache? No. Any swelling in your hand or feet? She will tell you, yes, doctor, I'm having swelling in my ankle. You know, pre-eclampsia sometimes can be presented with swelling. So ask her, when did it start and has it changed? No, it started like maybe a few days ago and it hasn't changed. Very important question to ask here after elaborating the hypertension. Ask her, are you able to feel the baby movement. Why here? Because I know that sometimes it can be complicated. So I need to check on the baby. And you will ask this question in any late pregnancy, like in any advanced pregnancy. Are you able to feel the baby movement? Now you finish the current health and the antenatal problem. Now take some past medical history. Ask her how was your health recently? My health has been absolutely fine. So very important here to ask her about the medical conditions. Like, have you been diagnosed with any medical problem? Please pick up the hypertension and the diabetes. Family history. Family history of pre-eclampsia is very important. So, any family member had any problem or complication during their pregnancy? No. Personal lifestyle. Ask her about smoking, alcohol, diet, and physical activity. Not conclusive. Now do examinations. Which examination? Again, vitals, general physical, abdominal examination. Very important sometimes to specify what you're looking for. So in the abdominal examination, he will say that I am looking for any epigastric pain. You know, you're doing the antenatal examination, not abdominal, no, antenatal. In the antenatal, we look for the symphyofundal height and if there's any pain anywhere. And about the presentation and the fetal heartbeat, like all items of antenatal examination. After the antenatal, you know that there are two complications of the pre-eclampsia, either respiratory edema, pulmonary edema, or eclampsia. So I need to do chest examination, and I need also to do neurological examination. Chest examination to see if there is any crepitations, and neurological examination to see the reflexes. The examiner will give you only the blood pressure is high. Other than this, everything else is normal in the antenatal. Like the fetal movement is normal, heart rate is normal, single fetus. Guys, there is two difference. If the girl or if the lady is 38 weeks pregnant, if 38 weeks pregnant, it means that the head should be engaged. But if she is 36 weeks pregnant, which means that the head is not engaged normal. So it depends. 36 weeks, I'm going to write it to you. 36 weeks, 36 weeks means not engaged. 38 means engaged. You will just verbalize it to that. The examiner will give you the finding. So after that, I need to do some investigations. Which investigations, doctor? I would like to do some urine tests. The examiner will give you 3+ protein in the urine. What 3+ protein in the urine plus high blood pressure is very suggestive of eclampsia. Dr. Yasmin, we do neurological examination for the fit, for the eclampsia, because she is eminent to have eclampsia. So I need to do, for the eclampsia, because actually she's having breast reflexes and she is liable to have fits in the case of pre-eclampsia. So I need to do neurological examination in case of eclampsia. So now disclose. From what you told me, it seems that you're having a condition we call pre-eclampsia. What is this? This is a complication in the pregnancy in which there is a raised blood pressure and protein in the urine. Why did I have it? It can be due to some problem in the blood vessel of the placenta. Don't say placenta, say the afterbirth. It's called afterbirth. Afterbirth. And in your case, actually, it could be also due to the first pregnancy. First pregnancy is usually a risk factor for developing pre-eclampsia. What are you going to do for me? We're going to keep you in the hospital. She usually is reluctant to stay in hospital, so address her concern. For example, if she wants like a maternity leave, or she will tell you, doctor, I can't leave work, you can provide her with a sick note. She is still reluctant. Now you explain to her the benefits. Why do we need to keep you in the hospital? Because we need to do further investigations to monitor you and your baby. Which investigations? Number 1, we need to monitor your blood pressure regularly. Number 2, we need to do some blood tests. Which blood test? We need to see liver and kidney function and blood clotting. clotting screen. So liver and kidney function and how thick your blood is, which is a blood clotting screening. So blood pressure regularly. Number two, some blood tests, and we need also to check the urine for 24 hours. Not only this, we need also to monitor the baby heart rate. So we'll connect the baby to the monitor. We'll connect her to the monitor, sorry. Okay, and we will also perform ultrasound. Why ultrasound? To check the blood flow of the placenta. So again, number one, some blood tests. Number two, measure the blood sugar, the blood pressure regularly. Number three, urine tests. Number four, we will monitor the heart rate of the baby by connecting her to the monitor. And ultimately, we'll consider doing ultrasound. Why ultrasound? To check the baby growth or to check the blood flow in the placenta. After that, we need to give you a medication to lower your blood pressure. Which medication? If she asks you, you will give her labetalol. Labetalol or nifedipine. Labetalol or nifedipine. Either oral or intravenous. But if intravenous, it's going to be labetalol or hydralazine. Hydralazine. So here, we give her usually labetalol oral. If not oral, then give intravenous after discussing with your senior. Okay? Okay. So, doctor, she will ask you, does this medication can affect my pregnancy? You can tell it's quite safe, but it can have some simple effect or small effect in your pregnancy. But you know, here the advantages of receiving it outweigh the advantages to control blood pressure. This is regarding the antihypertensive. And we'll also consider giving you some other medication for your fits. Which medication? Magnesium sulfate. Sorry, medication to prevent from having fits. Magnesium sulfate. How long should I stay in hospital? Okay, it depends. If the condition is well controlled, she can go home before she gets she delivers the baby. However, most of the times the patients will need to stay in the hospital until the baby is born. She will ask you, can I give birth naturally? Again, if the condition is controlled, she can give birth naturally. Otherwise, if it is not controlled by 39 to 40 weeks, or if the delivery did not start by 39 to 40 weeks, she may be offered induction delivery. So she will be offered induction, like by induction, any sort of induction, like maybe under oxytocin. But if the blood pressure cannot be controlled at all, and there is a risk to the baby well-being, she will have cesarean section. So again, if controlled, she can give birth naturally. If she did not give birth by 39 to 40 weeks, she may be offered induction. If the blood pressure is not controlled and the baby health is at risk, we will go for cesarean section. If she is still not convinced to stay in hospital, now you can explain the complications. What are the complications? Liver problem, kidney problem, blood problem, DIC, if you remember. Also, one of the problems is fit, having fit. Also, she can end up having stillbirth baby. One last question she will ask you, can I deliver in the pool? You will tell her that I'm afraid we need to monitor you before and during and after the delivery, which means that delivering in the pool is not possible. So, this is a pre-eclampsia station. I got it, and she's not cooperative. The problem is that the simulator is not cooperative at all. This is a problem. Otherwise, it's very nice station and very easy one. You know, the only twist is that we need to convince her to stay in hospital. We need to do, and we will need to do. So you have to explain the benefits, and you have to ultimately explain the complications. Now another station. She is female, the miscarriage station. She is female referred by GP for antenatal checkup after diagnosing pregnancy. So she is pregnant right now, and she is here for the antenatal checkup, and she has some concern. You will ask her, how can I help you? She will tell you, doctor, I have been referred by my GP for the antenatal checkup. Okay, so she has been referred by the GP for the antenatal checkup. So why did you go to the GP? She went to the GP because she had done pregnancy test and it came back positive, right? So the pregnancy test came back positive and she went to the GP and he confirmed the pregnancy. And the GP sent her here. So she is here because the GP sent her for the antenatal checkup. Okay, so now ask about the pregnancy question. For example, can you confirm the age of pregnancy, or can you tell me when was your last menstrual period? You know, if the pregnancy is near, I mean, like for example, started only a few weeks ago, you can ask when was your last menstrual period. But if the pregnancy is established and her tummy is meters before her, definitely you cannot ask her about her last menstrual period. Just ask her, for example, can you confirm your age of pregnancy? So in either cases, you can confirm the age of pregnancy, or if the pregnancy is recent, you can ask her when was your last menstrual period. Now ask her about the pregnancy. How has your pregnancy been so far? Any complications? What about any symptoms? She will ask you like what symptoms? What are symptoms of pregnancy, or what are the problems? Number one, any tummy pain. Number two, any bleeding or spotting. Number three, any discharge. Number four, you can ask her about any sickness. So those are symptoms of pregnancy. So I asked about symptoms and complications, as I told you in the pregnancy questions. Now ask her, have you ever been pregnant before? She will tell you, yes, doctor. I have been pregnant like twice before. When was that? How old? What was the outcome? She will tell you, doctor, I had two miscarriages. Two miscarriages, you have to reassure her and show sympathy and empathy definitely. And ask her, if she gives you miscarriage, you have to ask at what age of pregnancy. She will tell you, doctor, both happened at 8 weeks. So two miscarriages in the first trimester. Again, two miscarriages at the first trimester. So tell me more about them. She will tell you, doctor, I had some bleeding and I went to the hospital because of that. So what did they do there? They confirmed it and they gave her some advice. So I went to the hospital. What did they do in the hospital? They confirmed the pregnancy and they gave, so it was expected, the expectant management of the miscarriage, only expected. Wait and see. What about second time? Again, the same story. Bleeding, went to the hospital, confirmed it and observed her. Okay, but she doesn't know why this is happening. So miscarriage, I will ask when was that or at what age was that and what was done. Do you know the reason or have you been told about the reason? No, I do not know. Now move to the past medical history. How has your health been recently? She will tell you, doctor, my health is fine. What questions to ask? You can ask her about any fever or flu-like symptoms or any bad diarrhea? No. Any medical condition? What are the medical conditions which can lead to miscarriage? Number one, STIs. Number two, very important as well, hypertension. Any high blood sugar. Any kidney disease. So you can ask her about that. This is part of your antenatal checkup. Those conditions, you must ask about them. What else? Hypertension, kidney disease, high blood sugar, and STI. What else you can ask about? You can also ask about epilepsy, if she has any epilepsy or not. Do you take any medications? No. Family history of miscarriage? No. What is the important after the PMH and the OBG? The 4Ps. Ask about the 4Ps. Inconclusive here. Lifestyle. Lifestyle is very important because the lifestyle as well can contribute to the miscarriage. So you'll ask about smoking and diet and alcohol and physical activity. But one tip here is to ask her about, and it's very important actually, you will ask her about, I mean, if she tells you, yes, I'm smoking, ask her, have you been smoking in your previous pregnancies? For example, if she drinks alcohol, have you been drinking in your previous pregnancies? Like this. So always ask about this because you need to find out what is the reason of the miscarriage. Also ask about tea and the caffeine intake, the caffeine and tea intake. Now do examinations. Which examinations are important here? Vitals, general physical examination, and the tummy examination. Vitals, general physical, and tummy examination. Okay, the examiner will tell you everything is normal. So now the patient will ask you, doctor, why did I have this miscarriage? You will simply tell her that you had this miscarriage in the first trimester. If the pregnancy or if the miscarriage happens in the first trimester, this means that most probably it is because of some problems in the baby. Like, for example, chromosomal problems. What are the chromosomal problems? Chromosomal means that chromosome is the building block, the genetic building block. If there is extra or missing chromosome, this means that the pregnancy will not develop properly, and this will lead to miscarriage. Number two, another problem is the placenta problem, the blood supply to the baby, because the blood vessels run through the placenta, which is the afterbirth. Number three as well, you can tell her about the age of the mother. Age of the mother is having also an influence. Number four as well, obesity. Obesity is one of the risk factors of having miscarriage. Smoking. So now we can speak about the lifestyle. So again, chromosomal, placental, age of mother, and obesity. After obesity comes smoking and diet and physical activity and alcohol. Is there anything should I be doing? Now we'll advise you about lifestyle, like the diet. Maintain healthy, balanced diet. Alcohol. Do not drink alcohol. Here, I should say do not drink alcohol. Not drink in moderation. No, do not drink alcohol during pregnancy at all. Smoking as well. I will warn here. Physical activity. And I will warn her to attend her antenatal visits. Okay, she will ask you about any further miscarriage. Is it possible that it will come back again? You will just reassure her that it is a single event. And having one miscarriage or even two miscarriages doesn't mean necessary that you'll have it again. Doctor, what can we do to prevent the miscarriage? Again, I told her about the lifestyle modifications that she should do. Number one. Number two, very important, early ultrasound scanning. So again, lifestyle advice and early ultrasound scan. And reassure her that if she has 3 or more miscarriages, now further tests should be done. So if 3 or more miscarriages, 3 tests, now it is serious. So tests should be done. Which test? Ultrasound scan, see if there is any abnormalities in the uterus. Number 2, karyotyping. What is the karyotyping? Genetic testing in the partner and in the couple, like the husband and the wife. Why? Because if there is any chromosomal abnormalities, we need to detect them before the pregnancy. Number 3, antiphospholipid antibody test. Why? Because the antiphospholipid antibodies can increase the chance of the blood clots, which impair the blood supply in the placenta. So again, which test? Number 1, ultrasound. Number 2, karyotyping. And number 3, antiphospholipid antibody. And it will be done twice. The antiphospholipid antibody twice, 6 weeks apart from each other. So it will be done twice, 6 weeks apart from each other. If it is confirmed, she may take aspirin or heparin, or heparin. So twice, 6 weeks apart, and if it's confirmed, she will be given either aspirin or heparin, or even both together. Warning signs are the signs of miscarriage. If you develop any bleeding, please come back to us. However, if the bleeding is very less, don't worry, because this is common in the first trimester of the pregnancy. Okay, this is a station so far of the miscarriage. Any questions so far in the stations that we mentioned today? Okay. Let me just recheck the list again. We are now left with the contraception and the polycystic ovary. Let's move to the contraception station. By the way, this station does not come anymore in this pattern. Pool births, Dr. Kashi, pool births, which mean that, you know, in the foreign countries, they tend to give birth in swimming pool. Have you never, I mean, it's like, it's very common in the movies. They give in a swimming pool, like simple pool in their homes or such things, you know. And in this case, actually, you know, the pool or the pool birth, it needs to be, it's not monitored. So the pool birth is not monitored with devices, like no ultrasound, no cardiotopography, CTG, no such things at all. So definitely we cannot go for it in the pre-eclampsia. Okay, now in the contraception, actually she booked an appointment and she needs some advice about the contraception. So the task here tells you that she needs some advice about the contraception. Now ask her, Doctor, I want to discuss about the contraception. Okay, I'm here to address all your concerns. Which question to ask her? Do you have any particular form in your mind? Or are you using, for example, any contraception right now? She will tell you, yes, doctor, we are using condoms. Ask her, may I know why you want to change it? Because my new partner doesn't like it. So she just wants to change it because a new partner. Have you used any method of contraception in the past? She will tell you, yes, doctor. I used diaphragm, and I was disappointed because I got pregnant after it. So now, are you using any form of contraception? And may I know why you want to change it? So have you used any other form of contraception? She will tell you, yes, doctor. I use contraceptive pills, oral OCPs. And do you take them right now, or how, or why did you stop them? She will tell you that I stopped them 2 years ago because I had blood clot in my leg. So now you know that she is unfit to receive the OCPs. Why? Because she has blood clot in her legs. Ask her one question. Have you completed your family? I'm not sure, doctor. Me and my partner just got together and we need to sort this out. Is there any particular or specific form of contraception in your mind? I know this station is having very, like, it's not organized questions because it's all about the contraception and there is no pattern for the contraception. So you will ask her, are you using any form of contraception right now? And why do you want to change it? Have you used any form in the past? And why did you stop it? And ask her about any preference or did you complete your family? Now she prefers that she wants the contraceptive pills back again. Why? Because doctor, it was convenient to me. So now you know that she is unfit to receive the OCP, but still you have to take some past medical history. What will be your medical history here? Now, do you have any medical condition? She told you about the clot, which she had been receiving warfarin for. She has received warfarin for 6 months. You know, like any warfarin station or any warfarin case, we give 6 months. Any other medical condition? What are the conditions to ask in cases of contraception? Number 1, heart problem. Number 2, liver problem. Number 3, any cyst in the ovary. Number 4, any stroke. Number 5, any STI. Number 6, any cancer. You know the invasive procedures? You need to ask about any STIs, any PID, any cancer. Ask about any breast cancer, any blood problem. Ask about diabetes as well, any migraine, any thinning of the bone. So again, heart problem, liver, kidney problem, ovarian problem, any cancer. What about any breast cancer, stroke, blood problem, diabetes, osteoporosis, and migraine. Diabetes, osteoporosis, and migraine. Do you take any medications? No, she doesn't take any medications. After the OCPs, she stopped taking any medications. By any chance, do you use anything or any antibiotics? No. You know, because the antibiotics can interfere with the contraceptives. Do you have any allergy? No. Family history, any family history, again, any family history, same conditions, any family history of stroke, any family history of breast cancer. What about any liver or kidney problem or heart problem? This is OBG station. So after the PMH, usually you move to the 4-piece. Have you ever been pregnant before? Okay, yes, I have been pregnant. You know what was the outcome? She will tell you, doctor, they were fine. Why? Because if she told you that she's having ectopic pregnancy, this is contraindication for the invasive procedures. If you insert a coil, she will have ectopic pregnancy again. So when was your last menstrual period, and is it regular? So irregular periods, by the way, regular periods, no painful, no heavy flow, lifestyle, smoking and alcohol. You can ask about the lifestyle, no problem. Here you can do some examinations, but the examiner tell you that no need to do examinations, doctor. She's just here to discuss contraception. Okay, from what you told me, you are unfit to receive the oral contraceptive pills. Why? Because of blood clots. The pills will increase the risk of developing blood clots because they increase the chances of them. Okay, but we have other options. Which options, doctor? The other options are number 1, mini pill, which is a progesterone only pill. Number 2, the implant, the tube called implant, which is inserted under the skin of the upper arm. Number 3, the IUS, intrauterine system, the Mirena coil. Number 4, the IUCG, copper device. Number 5, sterilization. The mini pill is the progesterone only pill. The flexible tube is the implant. Just remember 2 or 3 sentences about each form of contraception. Why? Because this station is long already. Okay, so let's speak about what would you like me to speak about? She will tell you, doctor, speak about the pills first, the mini pills. What is the advantages or what is the, tell me more about them. Okay, the mini pills, simply, the advantages of the mini pills. Advantage is that they contain lower dose of hormone. So they contain only progesterone. They don't contain estrogen and progesterone together. And you can use it at any age. So contain only progesterone, and you can use it at any age. And as soon as you stop the pregnancy, the fertility will come back again. What about the disadvantages of them? See, any oral or any prolonged oral, it needs compliance. So it has to be taken every day at the same time. This is one disadvantage, definitely. Number two, sometimes it can cause some menstrual irregularities and some spotting between the periods. Number three, like any oral tablets, it can interact with any other medications, especially oral medications like antibiotics. So again, you will speak about the disadvantages. Again, oral, which means that it needs to be taken every time. Menstrual irregularities, number two. Number three, drug interaction. What is the failure rate of it? The failure rate is less than 1%. Okay, doctor, tell me about the implant. The implant simply, okay. The problem is the implant is that, or the advantage is first of all, it's implant, which means that it does not need to be taken every day. Just fixed in its place. And the moment you remove it, the fertility will be back again. I mean, she can get pregnant as soon as you remove it. One important thing as well and very characteristic about the implant is that the thickened mucus at the neck of the womb will prevent bugs from entering the uterus. So not only it is an implant, it's actually protecting against the PID. Why? Because it thickens the mucus at the neck of the womb. The cervical mucus is thickened here. What about the disadvantages of it? The disadvantages of the contraception or the implant is that, again, interaction with some medications, especially antibiotics. There are also some other medications, like some other side effects, like what? Some headache, some breast tenderness, some mood swings. Number three as well, some menstrual irregularities. So it's like the POP, but the only thing is that you will put the headache and mood swings and breast tenderness instead of the oral thing, which needs to be taken every day. What about the IUCD? The IUCD simply, the advantages of it, again, it is inserted. So we do not need to take it every day. And again, the moment it will be removed, the chance of getting pregnant again is so high. And it is one of the most effective methods of contraception. What about the disadvantages of it? Again, disadvantages are heavy flow or menstrual irregularities. This is number one. Number two, it can cause some PID or pelvic infection. You know this very well. Number three, which is very important side effect, is the ectopic pregnancy. Can cause pregnancy outside the womb. So PID and ectopic pregnancy and menstrual irregularities. What about the IUS? Intrauterine system or Mirena coil. Again, it is inserted in its space, so you do not need to take it every day. And it can be removed and the fertility returns rapidly. What about disadvantages? Again, some menstrual irregularities, but they are temporary, like the IUCD exactly. And you can also put that it causes headache and breast tenderness and change in the mood, typically like the implant. And very low risk of PID after inserting the IUS. And still ectopic pregnancy risk as well because it is inserted inside. So it's difficult. It's typically like the IUCD in terms of the complications. However, the chances of pelvic infection is very less here. What about the sterilization? Is it reversible, doctor, if I change my mind? You will tell her this is permanent method of contraception. And it's very difficult to reverse. Why? Because it involves removing the blocked part of the fallopian tube. So you will just, sterilization. Sterilization means that you will block and remove some part of the fallopian tube to prevent the fertilization in the tube, or to prevent, sorry, the transport of the embryo in the tube. So it is a permanent method of contraception. So you offered here all the symptoms, or sorry, all the options. Now she will think and she will get back to you. She will tell you, thank you, doctor, I will think about it and I will get back to you. Now in the end also you can tell her we can also offer you some leaflets to read again what we just said, or to go through again what we just said, in case you need to discuss them with your partner and you forgot about them. So always in the end of any consultation, lifestyle advice in the counseling sessions and such things, you have to offer leaflets. Why leaflets? Because it contains many options and the leaflets can cover all of them. So these are the stations so far. Let's discuss the recent one, or the most recent one, which is the PCO. PCO station is a very nice station, and it came in the beginning of April. In the beginning of February. It came 1st of February. Fortunately, you are FY2 GP, and the girl has come for test results. You can offer leaflets in every single station. What I mean, it's mostly in the counseling stations and in the counseling stations mostly, because you'll be given many advice. The patient may not be concentrating simply. The patient may be losing track. Or if you are discharging someone with a medication, new medication, especially the corticosteroids, or if you are discharging someone with long-term treatment, you'll definitely offer leaflets. Why? Because sometimes the patient may be confused at the moment, so the patient sometimes can be not in the mood to listen to you right now, so that you'll be offered leaflets to read at home and discuss with their relatives or beloved ones. Okay, luckily here you're FY2 in GP and the patient is coming for test results. She has been offered for the GP, or she has been coming for the clinic. She came 1 week ago complaining of some period problem like irregularity in the period, weight gain, and acne. So she had the triad: menstrual irregularity, weight gain, and acne. And the test results show: number one, BMI is 35. Number two, the pregnancy test is negative. Number three, very important now, the LHS to FSH, the LH to the FSH ratio is 3:1. So again, I'm writing it: LH to SFH is 3:1. This usually happens in the PCO, and the LH level is high, definitely. Why? Most probably this happens due to cyst in the ovary. Multiple cysts in the ovary produces luteinizing hormone, which leads to this ratio. BMI is high, which means that guys, it's having obesity. Talk to the patient, disclose the test results, and address her concern. Okay, now how can I help you? I'm here for my test results. Why did you do them? She will tell you, doctor, I haven't had any period since 6 months. And that's why I went to the doctor and he advised me to do a couple of tests. Okay, so now elaborate the presenting complaint. You told me that you did not have periods for 6 months. You mean that it was completely absent? She will tell you, yes, doctor. It started, I mean, like before the 6 months, it was light flow. But since 6 months, it didn't happen anymore. So the whole chain started maybe 9 or 11 months ago, and the complete cessation of the period was since 6 months from now. Okay. By any chance, no even few spotting in the past 6 months? No. So complete cessation of the period. Have you noticed anything else or anything else you have? You know that from the past she's having menstrual irregularity, obesity, and acne. So you will ask her, she will tell you, yes, doctor, I'm having acne on the face. This is spot, right? Like skin problem. When did it start? How did it start? Has it changed? Can you tell me about this, the shape? Just, like whiteheads all over my body. Okay, what about the size? Just spots, simple spots. Is it itchy, bleeding, painful? Like any skin problem, itchy, bleeding problem, itchy, bleeding, painful? Have you done anything for it? No. Okay, I told you that this is acne, so it's sometimes compromising problem to anyone. So have you done anything for it? Or how has this affected your life? Ask her how has this affected your life. Now she uses much makeup to hide it. So she uses many or much makeup to hide it. And it has caused affected her self-esteem. Okay. Do you have any other symptom? Yes, doctor, I'm gaining weight. So the third symptom is weight gain from the task. And she tells you, though I haven't changed my diet, but I'm getting bigger. So number one, lost periods. Number two, acne. Number three, weight gain. Ask about the weight gain since when it started and how did it start. Very good. How did it start? She'll tell you, doctor, it started together with my period and I don't know how. So what are your differential diagnoses for the weight gain? Can anyone elaborate, Dr. Muniba? Can you tell me what is the differential diagnosis for the weight gain generally? This sort of weight gain?
It could be polycystic ovaries, as in this case. It can be hypothyroidism. It can be just obesity.
Okay, so obesity is ruled out because she told you I don't have any problem with my diet.
Yes. Then hypothyroidism as well.
Okay, what else? Cushing. So
Sorry?
I'm Cushing. I'm just going to ask
Okay,
her,
question. Yes.
have you gained the weight? Have you gained the weight from everywhere? Like for example, do you notice the weight gain only in some places or everywhere? This question is very important in any weight gain station. Please do not forget to ask this question, guys. Even the obesity station, which we did not discuss yet, and I did not forget about it, we're going to ask this question. Okay? Okay, so now you asked about these things. What is the next problem, or what is the next question? I asked right now about the history of the presenting complaint. Now let's move to the associating symptoms. Anything else, she will tell you, yes, doctor, I noticed some hair on my face. So this is hirsutism. So now you are having acne, weight gain, menstrual irregularities, and hirsutism. Can you ever think about any other condition than PCO? And from the test results as well outside the cubicle, you know that this is definitely PCO. Why? Many cysts in the ovary, they produce LH, much LH. That's why the LH hormone is high. So right now now I knew that PCO, even if you did not know about this station before. Okay, now I knew that it's PCO, so I need to ask some more two or three questions about the PCO. What are the other two questions of the PCO? For example, you can ask her about, what about, you told me that hair, you have hair in your face. Have you noticed any hair loss by any chance? No, no hair loss. The DDs here, in this case, the DDs or the differential to the PCO are number one, diabetes, number two, Cushing, number three, hypothyroidism. Diabetes, Cushing, hypothyroidism. So I asked about the presenting complaint number one, number two, associating symptom, any hair loss, number three, DDs, which are Cushing. I asked about this I asked already about it by, do you notice the weight gain is all over your body or in certain places like your tummy and shoulders? The second differential is the hypothyroidism, and the third differential is the diabetes. How to ask about diabetes? Do you feel more thirsty these days? Do you go to the loo more often? Now move to the past medical history. Past medical history, not conclusive at all. Ask the questions of the past medical history, it's fine. Personal lifestyle. About the diet, she already told you that she eats healthy, balanced diet. Physical activity, not really. She doesn't smoke. She doesn't drink alcohol. And she is a teacher. So lifestyle is not important here because you already diagnosed the condition right now. Do not forget that this is sort of gynecological complaint. So in any female in PLAB 2, I told you to ask about what? Ask about the four-piece. We already asked about the period because she's presented with menstrual irregularity. So ask here, for example, about any method of contraception. Have you been pregnant before? Okay. How has this affected your life? You already asked her, how has this affected your life, all these problems? She will tell you, doctor, actually, I have been a single a long ago because of this. So see, this has affected her self-esteem and even affected her sexual health or her relationship. So now I'd like to do some examinations. Which examinations? Abdominal and bimanual. Why bimanual? Because this is gynecological complaint. Any gynecological complaint, we need to do the bimanual. Okay, management. What is the management? What is the test result, doctor, please? She will tell you, you will tell her that in your test results, we found some level of hormone is high. It's called the utilizing hormone. Do you know what the name of this condition? What is this, doctor? You will tell her right now you're having a condition we call polycystic ovary syndrome. So the test results show high luteinizing hormone, very high actually, which is remarkable for the pelvic, which is remarkable for the polycystic ovary syndrome. Okay, no, it doesn't run in the family. It's not necessarily running in the family. It has no relation, and acromegaly is very unlikely. She doesn't show any problem here. You can ask about the mood as well, or psychosocial definitely, Dr. Zaid. So what is PCO, doctor? Polycystic ovary is a condition affect the ovary of the woman, which show three main features. The triad of the polycystic ovary is irregular period. Number one, irregular period, like in her case. Number two, excess androgen. Excessive androgen, which leads to the hair growth in unusual size, like the facial hair that she is having. Number three, the ovaries itself. The ovary itself, it shows many cysts. Many cysts or fluid-filled sac. So polycystic ovary, irregular period, and excessive androgen. She will ask you, doctor, is it the cause why I've been missing my period? Actually, simply, yes, it is the cause. You know how the PCO prevents her from having the period? It's very simple. The LH hormone. The LH hormone, it does not allow the ovary to release the eggs. The LH hormone, it does not allow, the high level of it does not allow the ovary to release the eggs. So, and that's why she is getting irregular period. So if the ovary do not release eggs, this means that she will not end up having period, because you know the period or the ovulation is the release of the eggs. High luteinizing hormone will not let her have these periods or having the ovulation. Together with the high level of the androgen, the male hormone, which leads to her to have hirsutism. So high level of male hormone inhibit or affect the period, and high level of luteinizing hormone does not let her to produce the ova or the eggs. Why did I get it? The exact cause is unknown. Just hormonal imbalance, and very few times it can run in family. However, it's most probably unknown. Okay, now you know only the test results. Still, you know the test results are not confirmatory for the PCO. So you need to do further tests. Which test? Definitely, you will run further hormonal analysis, like you will measure the testosterone, the cortisone, and you will also measure the blood sugar. Why the blood sugar? Because actually the risk of diabetes is high with the PCO. And you will do also high cholesterol. You will check for the cholesterol. Why? Because the risk, you know, obesity leads to high blood sugar and leads also as well to high cholesterol. So I need to check for the blood sugar and for the cholesterol. So cortisone, testosterone, cholesterol, and sugar. What is the most important test here? Ultrasound, to visualize the cyst. So if she asks you why diabetes, because actually diabetes is one of the complications of this condition. Now comes the most important question. She will ask you, doctor, will I be cured? It is not curable. Only symptomatic treatment is applicable. Okay, now if you diagnose her with PCO, actually, in this case, you can refer her to specialist. The specialist sometimes he can guide her about the pregnancy. I mean, the specialist is mainly for the pregnancy issue. Or she can even be referred to endocrinologist for the diabetes issue. So pregnancy and diabetes. I need to refer her to endocrinology and gynecology for that. However, the symptomatic treatment is usually at the GP. Okay, now I will give her some lifestyle changes. Which lifestyle changes? Lifestyle for the obesity, maintain healthy, balanced diet. Why? Because actually she's obese. We measured her BMI and it was high, so she needs to maintain healthy, balanced diet and she needs to lose weight. Are you going to give me some medications, doctor? Actually, for her, some medications will be beneficial for her, and it will be given by the GP. Which medications? The medications to induce regular period. Um, you can sometimes give ovulating medications to her to stimulate the ovulation. Clomiphene citrate, you can give it to her in this case, but do not mention the name. Just we're going to give you some medications to induce your ovulation or regular period. And some medication, symptomatic treatment. So symptomatic is medication to induce the period. Number 2, medication to control the hair growth. Okay, and medication for the acne. Okay, and also we can give her some medication for the cholesterol. So irregular period, acne, hair growth, and the cholesterol. She will ask you, will I get my period again? Most of the people will get the period again. We can prescribe for her some things to induce her ovulation. Like what? Contraceptive pill. Contraceptive pill can induce her regular period. However, some irregularity in the beginning, but it can, after the long time or after some time, it can induce regular period. Or any other contraceptive methods. So the contraceptive methods are the main method to induce regular period. Now she will ask you, so for the period you will give contraceptive methods. For the pregnancy, now for the pregnancy, we can refer her to gynecologists. Or you can simply tell her that with the treatment, most of you will be able, or most of the patients will be able to get pregnant. So you can refer her to specialists to discuss the pregnancy options with her. Most of them are injections that I told you, the injections that induce the ovulation, or maybe ultimately in vitro fertilization. In vitro fertilization. And for the hair of the face, you can simply tell her that as well, the contraceptive methods can help you with that, because the contraceptives contain hormones. So these hormones will definitely act against the male hormones. And also we can offer you some medications which block the male hormone locally. Remember the danazol. And also you can be offered some laser therapy. Laser therapy for the facial hair. So again, let's sum this up. For the period, we're going to give you some medications to induce your period, like the contraceptives. And after a while, you can be able to be pregnant with that treatment. However, we can refer you also to specialists to discuss the pregnancy options with you. Like what? Like maybe injections and in vitro fertilization. What about the acne? The acne, she will use some creams for it. Simple creams and simple measures. What about the hair loss or the hair growth? Sorry, she will use some laser treatment. She can use also male blocking medications, male hormone blocking medications like maybe danazol, so danazol or laser, or even with the contraceptives, it will resolve. What about the diabetes? Definitely we'll monitor her blood sugar and we may consider giving her some advices and maybe some pills. What about the cholesterol? We will give her some statin as well. So is it curable? No. Usually you need to take medications. Symptomatic treatment at the GP and definitive treatment for the pregnancy can be done at a specialist. This is the station so far. And why did she get it? No reason. No problem, Dr. Zaid. No problem. Take your time. Why did she get it? For no reason. Most probably no reason. And most probably it can run in families as well. So this is the station so far of the contraceptive, for the PCO. Now I'm going to give you a few minutes rest and we will be back and we will start the pediatrics stations. For the pediatric stations, we are having around 13 stations from the pediatrics, or even 14. If we keep the same pace, we will finish at least maybe 14 of them. We can finish at least 10 of them if we keep this pace. Or even we can finish all of them actually, because they are easy. The hardest part is over, the OBG. So take a few minutes break, and when I'm back, I will contact you on WhatsApp. Hello, guys. I just posted on the group right now for the people to come back. Where are the others? Many people left. Okay, so we are starting the PC stations. In the PC station, simply we have to discuss the number one. We have to discuss the febrile convulsions station. First of all, before starting the febrile convulsions, I need someone to tell me what are the questions to be asked in the history, like quickly. What are the questions to be asked in the history of the febrile convulsions? Like, for example, the task here, the task tells me that the patient was having, the patient is 4 years old, the patient, and she was having some convulsions or some fits, okay? And the mother is here because she's having some concern regarding the treatment of the baby or the, sorry, the treatment of that child. So I need someone here to help me with that. Can anyone help me with that? Like, for example, which questions? The task here, one more thing as well. The task here tells you that the temperature was measured. I mean, she's having fits, the girl or the baby or the daughter, sorry. The child has fits, and you have measured the temperature, and it was found to be higher. So can anyone help me with that quickly before till the others come at least? And we can speak about that.
Hello.
Okay. Hello.
Yeah. Could you please tell me what happened?
Okay, now, Dr. Limi, I told you that she had fits, and I elaborated the fits in details. Like, for example, she was having jerky movements all over her body, and it lasted for 2 to 3 minutes. Okay, and the doctor after that, I called the ambulance, and they brought her here. Yeah, Dr. Limi entered it in the right way. Keep going,
Okay. How long did the jerky movement last for?
Dr. Yemi. I told you for 2 to 3 minutes.
Okay. Did it involve the hands and legs?
Yeah, all over the body.
Okay. Did your child lose consciousness?
Sometimes no, but mostly no.
Okay. Is this the very first time it's going to be happening?
Yeah, it's the first time, Doctor.
Okay. Did she vomit? Any vomiting?
No vomiting, Doctor.
Okay. Did she wet herself?
No, she didn't wet herself.
Okay. Okay. All right then. I would like to ask you some few questions about her general well-being.
Okay.
Okay. Any cough?
No, doctor, but she was just having flu-like illness recently, like 2 weeks ago, and after that she developed some sort of like pain in her ear, or some like she was pulling the ear. I think that's why she was having pain. I think now you knew
Okay.
what is the reason of the febrile convulsions to him,
Yes.
right?
Hello.
Yeah,
Yes, I do.
right.
Hello.
Yeah. Can you hear me?
Yes, I can hear you.
Okay, so now you know the reason for the convulsions, right?
Yes, I do. Hello.
Keep going. Keep going.
Okay. Any discharge from her hair?
Okay, you mean discharge? Yes, doctor. There was some discharge. It's most of the time she will tell you no discharge, doctor. Okay, I'm sorry, Dr. Yemi. I told you that the ear problem has been there for the past 1 week, right? No, it's not 1 week. It's just 2 days.
Okay.
2 days and sometimes 4 days. And I will tell you what is the difference in a while.
Okay. Okay. So any headache?
No headache.
Okay. What about rash?
No.
Okay. Does she shy away from light at any point in time?
No, doctor.
Okay. Any passage of watery stool?
No.
Okay. Could you please tell me about her urine? Does her urine get smelly?
No.
Okay. Any cough?
No.
Okay. Tell me, does she get you wet her diapers more than often?
No.
Okay. Okay. Is she on any medication?
No.
Okay. Any form of allergy?
No. Very good.
Is there anybody in the family who has this kind of illness?
No.
Okay. All right. Thank you. Could you tell me please about her birth? Any
Her,
complications during birth?
her birth was absolutely fine.
Okay. Are jabs, is it up to date?
Yes, she's up to date with the jobs.
Okay. What do you feed her with?
Breastfeeding.
Okay, that's good. What's a D? Thank you
Guys,
so much.
you asked about the feed, you asked about the feed, the poo and the wee, like in many cats. Dr. Amy, very good. Seriously. You ruled out what are the diseases? You ruled out pneumonia, you ruled out UTI, you ruled out GIT problems. You know the causes of the fever. You ruled them out in the pediatrics. And you asked about family history. You asked about very good. Your history was very good, but just you meant one thing only, that you did not ask about what happened after the fit. Did she have, like, for example, did she feel drowsy after the fit? Did she vomit after the fit? After the fit, not before, okay?
Okay, thank you.
Seriously, you were very good. You were very good and concise in the history. I like it, seriously.
Thanks.
You're welcome, Dr. Yemi, but I just need to point one thing, please, Dr. Yemi.
Hello? What did you say?
Yes, I need to point out one thing to you. I noticed that not only you are not the only one who keeps it, but you know, saying okay many times will be a time waste for you. I know that many people are having this tick in their words, but just, I mean, you know, try to nod your head, very simple. Try to acknowledge what the patient is saying by nodding your head. Sometimes, not necessarily that you acknowledge everything said. For example, does he have any fever? No. Okay. Does he have any? This will take you at least 30 seconds throughout your station. So why do you do this? You can save your time by saying, I mean, for example, does he have any fever? No. What about any swelling? No. Any situation? No. Like this. Not necessarily to say, all right, about each and every question. This is just for your time being. So here, as Dr. Yemi did, number one, I will elaborate. Thank you, Dr. Yemi, so much.
Thank you so much.
Thank you. So guys, tell me please, is my voice interrupting? Any problem with my voice today? I don't know why, because I feel that there is some noise in my voice or some interruption in my voice. My voice is interrupting Dr. Rivera, right? And I asked it, by the way, no one told me. Okay. So here, Dr. Yemi, no, it was not. Oh, wait, really? You told me, yes, you told me something about the sound. Yes, I'm sorry, Dr. Rivera. No, you said I lost sound. You are the only one who said about it. Yes, I didn't get it. I thought that it's a problem from your side. Oh, stop it. Stop it, Dr. Rivera. Do not make me feel guilty, okay? You know that I didn't realize this. I asked in the beginning of the session, by the way, even before you come, I asked, is there any problem with my voice? Nobody answered. So I thought it could be from your side. I'm sorry. I'm really sorry, Dr. Rivera. I didn't mean that. Okay. So, so now, as Dr. Yemi did exactly, he elaborated number one the fits, and we are elaborating the fits. Thank you, Dr. Nigar. Before, during, and after. Before, during, and after is very important, as Dr. Yemi exactly did. So in this case, before, during, and after, you elaborated it. And after the fit, have you noticed anything unusual or anything else? She will tell you yes about pulling the ear. Pulling the ear means ear pain in the children. Anything else, like since when it started, how did it start, has it changed? Anything else, like it's a charge, any swelling, any redness? Now I have to rule out the other DVs. What are the differentials here? The differentials here are number one, meningitis. Number 2, pneumonia. Number 3, UTI. Number 4, GIT problem. You mean all the causes which can cause febrile convulsions. So after that, you can also add the birthday questions, very important. And you also can ask about who takes care of the child. Why? We need to rule out non-accidental injury in any pediatric case. What is the D, Dr. Yemi? What about her diet or her feeding? D stands for diet. So what about her feeding? Any problem with the poo? Any problem with the wee? It's very simple. Okay, now ask about the febrile convulsions. Febrile convulsions management. So she will tell her that to the doctor, before management, definitely you need to do examinations. You will do all the examinations, including chest examination, and you have to do ENT and neurological and yes, ENT and neurological and tummy examination. Why ENT? Because you need to examine the ear. Okay, the examiner will tell you findings are similar to your test. The test here show redness in the ear. So definitely this is otitis media. So after the chest is clear and everything else is fine. Now move to the next thing. What you are going to do investigations, routine blood and urine. So the investigations are normal here. Doctor, what's going on? From what you told me, she had a condition we call febrile convulsions. What is febrile convulsion? It is a fit that happens due to high temperature. So from its name, fits due to high temperature, and it happens between 6 months to 5 years of age. Why did my baby have this problem? Because she had high temperature. Definitely because of the problem in her ear, which we call otitis media. Is it dangerous? Is it permanent, doctor? Okay, not dangerous. Why? Because there's a cause for it. I mean, the cause has been identified. Okay, and also the children recover from it. Usually, the children grow out of this condition. So the cause has been identified. There is identifiable cause, and the most of the children will grow out of it. Okay. Okay. Um, so, doctor, is it epilepsy? You have to explain the difference between the epilepsy and febrile convulsion. This is due to fever, and this is due to abnormal electrical activity. One controversial question. She will ask. She will ask you. She will ask you about. Wait, guys. Wait. Okay, so one controversial question is going to ask you, Doctor, will it cause epilepsy in the future? Okay, guys, the chances of for the children having epilepsy, I mean the children who had febrile convulsions, are little bit higher risk to develop epilepsy in the future. I mean, higher risk, slightly higher risk than the other children, which did not or who did not develop febrile convulsions. Having said that, mostly it doesn't cause epilepsy to develop. So if she asks you, Doctor, will she have it again in the future? Her age is 3 years, maybe, or 4 years. So you can tell her that I told you that it happens between 6 months and 5 years, so she can have it again. However, she will grow out of it. Okay, but one important thing, she doesn't have any signs of recurrence. She had it only once, and the cause was identified, and also it happened at low temperature. It didn't happen at low temperature. The temperature here was 39, so it happened at high temperature. So there is no risk of recurrence. Risks of recurrence are high temperature and long fits as well. And family history. So how can you prevent it? Simply by maintaining the body temperature lower. Doctor, what should I do if it happens again? If it happens again, like any fit, put her in the safe position, the recovery position. Remove any sharp objects. Don't put anything in her mouth. But if the fit lasts more than 5 minutes, please come back to us. Does she need any medication? She doesn't need medication because this fit is self-limited. Okay, this is number one. Number two, for the high fever, here comes two scenarios. If she's having the fever or she's having the otitis media since 2 days, you can only give paracetamol. But if 1 or 2 days, so we're going to give paracetamol. Okay? Okay. What if 4 days? 4 days or more. 4 days or more, we're going to give paracetamol and the antibiotics as well. So the otitis media can be treated with antibiotics if 4 days or more. So here you're going to give her paracetamol. Doctor, you will not give her any antibiotics? Now you can tell her she doesn't need antibiotics. Why? Because actually the infection just started 1 day ago or 2 days ago. Having antibiotics unnecessary will develop antibiotic resistance and some side effects. However, we review her in 3 days or 2 days from now, and if her condition is not improved, we will definitely prescribe antibiotics to her. How not improved? For example, if she developed any discharge or if the pain is not feeling better, we will definitely prescribe antibiotics. Okay, what about if the fever or if the condition is 5 days, 4 days or more? If 4 days or more, we are going to prescribe her antibiotics. Antibiotic course for 5 days. Which antibiotic? You asked her about the allergy. By any chance, is she allergic to penicillin? No, doctor. So I'm going to give amoxicillin for 5 days. If she's allergic to penicillin, you are going to give clarithromycin. So here I will give amoxicillin, but if allergic to amoxicillin or penicillin, we're going to give clarithromycin. She can ask you, doctor, won't you give her any medication to pull through the back passage in case she gives the fits? Usually we prescribe these medications if the fits are recurrent or if you live at a significant distance from the hospital. She means definitely the rectal diazepam. Doctor, can I take my baby home? Definitely your baby is safe right now and she's absolutely fine, but we need to keep the children who have the first fit at the hospital. So because it is the first seizures or the first fits, we need to keep her in the hospital to observe her. If she asks you about the other kid or the other child, will she have the other problem? You can ask her how old is he or she. She will say, for example, 2 or 3 years old. This means that still they can give this problem because it happens between 6 months and 5 years. This is the longest management, but this doesn't mean that you need to cover all of it. Those are all concerns that she can ask you, but this doesn't mean that she will necessarily ask you all these concerns. Okay? This is the easiest, this is the first pediatric station. And I think all of you, anyone who appears for PLAB know about it. Okay. Next station is non-accidental injury. The non-accidental injury, simply let me pick the task for it because you need to read it well. The task. I'm just going to look for its task. You're FY2 working in pediatric department. The patient is 4 months old. 4 months old. Brought to the hospital by the mother this morning. She rushed to the hospital after she noticed a swelling on his right arm. Other information, the X-ray has been done and it shows spiral fracture. So there is a spiral fracture of the right humerus. Talk to the mother, assess the child condition. Special note, your nurse colleague is looking after the child in the next room. So the child is not in the room. The child is in the next room. And the mother is very worried. What does this mean, the mother is very worried? This means that she will keep pushing you in the beginning to disclose what's wrong with her baby. She will not let you take detailed history and such things. Okay. How can I help you? Doctor, how is my baby, doctor? May I know how is he? Is he alright, doctor? Tell her that he's okay at the moment. Where is he, doctor? Where's my baby? Or where is she? No, where is he? Where is he, doctor? Tell her that he's in the next room. My nurse colleague is looking after him. Okay, doctor. May I know why you are worried or why you brought him here? Doctor, because he had swelling, doctor, and I was worried on him. That's why I brought him to the hospital. Doctor, what's happening to my child? So, she will not let you ask her any question. She will keep insisting on you, what's wrong, what's wrong, what's wrong. So now you can tell her that you brought him to the hospital because he had swelling. We took X-ray and it showed broken bone. You know, this broken bone, fracture means broken bone. I'm saying that you're telling the patient he has broken bone. You know, guys, this is spiral fracture. Usually, spiral fracture doesn't happen at this age. Okay, the common fractures in the children are the green stick. Green stick fractures happen because the bones are flexible. They are still, you know, flexible, like they're very flexible. So the chance of having some sort of spiral fracture is very unlikely in the children. This means that there has been some very bad force which happened to them, external strong force. So the chances of non-accidental injury is very high. Yeah, that's how we will pick up the non-accidental injury. This is your clue. Spiral fracture is very uncommon in children. The only way is direct blow or direct external force. So, doctor, is he in pain now? He's having broken bone. Is he in pain now? You can tell her that we give him enough painkillers, and my nurse colleague has taken him or is taking care of him in the other room. So ask her a few questions. Can you tell me what happened exactly? She will tell you the whole story. She had night shift. She ran after she came back to the house. She noticed that he had swelling on his right arm, and she brought him here. She rushed to the hospital, and she will tell you the whole story, which is written in the task. When was that, doctor? I just came back home 2 hours ago. Okay. Now ask her a few questions. Now you know that this is not accidental injury, right? What are the priority here to be asked? You can ask medical history in the beginning, no problem. Like, are you aware of any medical condition he's having? Like, for example, any bone problem? Does he take any medications? Like this. You can ask past medical history. But here, I think the important thing is the social history. You need to pick the social history in the beginning. What is the social history here? Number one, who's looking after your child or who looks after him? Doctor, when I'm in the night shift, doctor, you know, my boyfriend. First question to ask, is he the biological father? No, doctor, he is not. How long have you been together? 6 months. How is his relationship with your baby? Doctor, it's fine. Does he usually take care of him? Um, yeah, doctor, it has been like a couple of times since he takes care of him. Okay. Did you talk to your partner about that happened or about anything happened in the last night? She will tell you, doctor, he just told me that he had a hard time. So, The partner, I need to know if he's a biological father and if he usually takes care of the child or not. Have you talked to him about anything? He will just mention that he had hard time. May I know why hard time? Because the baby was crying too much, but I didn't have the chance to talk to him in details. Okay, so I asked about everything. How is his relationship with the baby? Now the mother will start being anxious. Why I'm asking all these questions? Because I need to know the relationship between the boyfriend and the baby and how was the last night. So she will start getting anxious here. Anyone else take care of your baby? No. We asked about the medical history. Okay. Now ask some questions like the birth questions. What are the birth questions? How was his birth? Is he up to date with the jabs? Any complications during the birthday? Is he up to date with the jabs? Are you happy with his red book? What about his feeding? Any problem with the wee? Any problem with the poo? Like the birth questions. Now do examinations. Which examinations? All the examinations. You know, anyone who had a fall, if this fall is elder, if he is child, if he is whatever, just do full body examination. Full body examinations. Okay. Investigations, the examiner is not interested. The management. From what you told me and the investigations we have done, we have to keep your baby in the hospital. Here you do not tell that he's having non-accidental injury. No. You have to keep in the hospital. You do not confirm non-accidental injury except after running series of investigations. So non-accidental is usually diagnosis of exclusion. Why do you want to keep him in the hospital, doctor? Because we took X-ray and it showed broken bone. We will refer him to specialists to stabilize, to manage the fracture definitively. So number one, we need to refer him to specialists to be definitively treated. We need also to run further investigations to look for the cause of fracture. So guys, again, admit, refer to specialists, do investigations, and inform senior or involve senior. Why you are informing senior? Guys, remember in the domestic violence cases, any social problems like what? Social problems like maybe domestic violence, like maybe non-accidental injury, like elder abuse. These things, please always inform senior. Okay. So again, you are supposed always to involve senior in case of any social problem. Okay, doctor, but why senior, doctor? I don't want to talk to the senior. May I know why? She is worried. She needs no one big to be involved in this matter because she knows that there is a problem happening. Okay, so now you will tell her, or she will tell you, doctor, I just don't want the senior to be involved. Okay, right now what you're going to tell her? I'm going to tell her that we actually need to involve our senior because we need to take the best possible decision for your little one. We need to also do further investigations to him, for which we need to involve our senior before doing that. So senior is involved in case of series of definitive investigations as well. Which investigations like CT scan of the tummy, like some other things like bone scanning to see if he's having any weak bone, liver, and all body exam. You remember the fallen elder? We will do the same investigations here. All investigations. Doctor, why all these investigations? You will simply tell her we need to do them because this sort of fracture is high unlikely in this age. Doctor, why unlikely or why unusual? Because children are having flexible bones in this age. What do you mean, doctor? You will simply tell her that this fracture doesn't happen due to simple mechanism. This sort of fracture suggests something like external force has been applied. Say it in a low voice and pause. External force has been applied. Low voice and pause. please. Do you mean someone did this? So now she is trapping you. Do you mean someone did this, doctor? You will tell her, actually, we need to do further investigations, like maybe blood tests and some bone tests, and to rule out some medical problems and bone conditions. However, as I told you, this sort of fracture doesn't happen with a simple mechanism of fall. Therefore, there is a possibility that it could have been done by someone. Therefore, I'm afraid there could be a possibility that it was done by someone. Doctor, are you saying he's a boyfriend? Is my boyfriend? He's a very nice person. He loves my baby. Now we assure her that we are not here to blame anyone. We are not trying to blame or accuse anyone. As doctors, we need to follow the protocols. We need to exclude all the medical causes and all the possibilities. However, I'm afraid, as you told me, that your boyfriend was the only one with the baby last night, so it could be him. Or it could be a possibility. That's why I told you this is a very sensitive matter and I need my senior to be involved. So here, this is a sensitive matter. As FY2, you are not experienced enough to doubt these things or to diagnose these things. So you need to involve the senior because this is a very sensitive matter. And actually, if ever social services to be involved, you will do it through the senior. You cannot do it on yourself. You're just a little helpless FY2. Always remember this, okay? Okay, so now, what's next here? So you can ask you one question, doctor, what if it's confirmed to be so? You will tell her part of hospital protocol will involve social services. What will social services do? Definitely, they will go to the home. Social services go to the home to assess the safety or the condition of the house and safety of the baby. Doctor, please do not involve them. Are they going to take my baby away from me? Reassure her that the aim of this is to help and support your baby and you. No one can take your baby away from you. Just you need to assess the risk to your baby. Doctor, I want to take him home right now, please. Now it's not her decision to take him home, guys. It's not her puppet to take her home. This is a baby, this is a soul, and the baby is at risk. So what you can do, you will tell her that we need to confirm our investigations. We need to keep him in the hospital because we need to refer to specialists to stabilize the fracture. Number 2, we need to do further investigations. Number 3, social services should be involved. So that's why we keep him in the hospital. This is the station so far. So the core of this station is that you are not going to say non-accidental injury like frankly. Don't do that. Okay? Okay. So next station is head injury in the child. First, before moving, has anyone got any doubts so far or anything? Dr. Zaid, the management here, you're going to do number 1, further investigations. Which investigations? You're going to do full body investigations. For that, you are going to keep him in the hospital and you need to inform the senior. If the investigations come back normal, this means that unfortunately it could be done by someone. Why all this investigation? Because this sort of fracture is very unlikely because the bones are very flexible. Doctor, do you mean my boyfriend has done it? We are not blaming someone. We need to exclude medical causes. However, if everything comes back normal, this could be a possibility because he was the only one who was looking after your little one last night. No, now, what if it's confirmed? You will inform social services to do risk assessment in the house. They cannot take the baby. They are just doing some risk assessment for her and for the baby. And they're going to talk to the boyfriend as well. And she cannot take the baby home because you need to keep him for many reasons. Number 1, definitive treatment of the fracture. Number 2, senior review. Number 3 as well is that further investigations. Number 4, social services. So this is the station so far. Is there any problem with my voice again? Was it interrupted again? Was there any problem with my voice? Was it interrupted? Okay. Next station is the head injury. Let's sum this station up. Simply a child who had head injury. The problem is that after the head injury, the child was feeling drowsy and sleepy. So after the injury, he was feeling drowsy and sleepy. But he vomited only once after the fall. One episode is not an indication for CT scan. Maybe 3 episodes, 2 or 3 episodes can be indication, but not one episode. And he has nothing else at all. He has just one bruise which is very small, like maybe 1 or 2 centimeters. So how do you elaborate the fall? She will tell you, doctor, now she's worried. Why? Because the baby had a fall. This is a task. The task tells you that you have to, in pediatric emergency, the baby had a fall. Talk to the mother, and your nurse colleague is looking after him in the next room. Doctor, my baby had a fall. Don't worry, he's in good hands. My nurse colleague is looking after him. Tell me what happened. She will tell you, doctor, 2 hours ago he fell from the sofa. Okay. Okay. So now I'm going to elaborate the fall before and during and after. Before, he was fine. During the fall actually, no loss of consciousness, no fits at all. So I'm going to ask about loss of consciousness and fits. But she will tell you, doctor, he has been crying during the fall for a few seconds. What after the fall? Anything unusual after the fall? Like what, doctor? Like any vomiting? Yes, doctor, he vomited once. And once in the ambulance. Did he injure the head? Yes, doctor, there is a bruise on his head. You have to ask about the size of the bruise. She will tell you, doctor, it's just very small. Okay. Anything like, did he feel sleepy or drowsy? Yes, doctor, he felt sleepy or drowsy for a few minutes. So sleepy or drowsy for a few minutes is an indication for the CT scan. Anything else? Like what, doctor? Any injury elsewhere in the body? No. Did he have any seizure or any fits in his body? No. So what are the questions? Vomiting. Number 2, sleepiness or drowsiness. Number 3, head injury. Number 4, any injury elsewhere. Number 5, any fits. Past medical history. What are the reasons for the fall? Like the elder exactly. Infection. This is number 1. Number 2 could be hypoglycemia as well. Like I can ask about diabetes. It can be also some heart racing. Like the elder exactly. So I'm going to ask, did he have any fever or flu-like illness? What about any cough? Any shyness to the light? So symptoms of infection. What are the other things to be asked? Does he have any blood disorder? This is an indication to the CT scan. Has he been diagnosed with any diabetes? No. Birthday questions. Ask about the birthday questions. After that, you have to ask some social history. Why social history? In any pediatric station, you have to rule out non-accidental injury. Please, you have to ask, or you have to rule out non-accidental injury in any pediatric station. Okay, so you have to rule out any non-accidental injury, please. Which examinations? Again, this is a fall, right? Like the non-accidental. All the body examination, ear, eye, chest, heart, tummy, neurological, musculoskeletal, all the examinations. In the examination, the examiner will give you bruise on the forehead, and everything is normal. So what is your management here? You are going to keep the baby in the hospital and ask senior to review. Why senior review? Because this is a fall, this is an emergency. So in any pediatric case, especially if it is emergency like a fall, you need to keep in the hospital and you need to ask the senior for review. I told you, keep in the hospital, number 1, number 2, senior review, number 3, symptomatic treatment, number 4, definitive. Doctor, but why, doctor, why you wanna keep her in the hospital? She's fine. When someone is against this, we need to ask what's your concern. She will tell you, doctor, I have another kid. Can't you ask someone else to take care of him or her? Okay, doctor, I can arrange it. So, doctor, why are you going to keep him? Because we need to have a closer look at him to make sure that everything is fine. For how long? Okay, simply here in this case, simply you can ask her or you can tell her that it can be for a few hours. Why? Because he has been feeling drowsy or sleepy. So being drowsy or sleepy is an indication to hospital admission, and sometimes we may need to do CT scan. So you're not going to do CT scan like for sure. No, you just will keep her under observation because she has been feeling or he has been feeling drowsy or sleepy for a while after the fall. So it will be important to keep him or her in the hospital. Okay, doctor. And as well, we may need to do CT scan. Why, doctor, CT scan? He is fine. Actually, at the moment, we will not need CT scan as well so far. But, and sometimes we may consider doing CT scan as a possibility. Why possibility? Because she's feeling drowsy and sleepy for a while. So in case if there's anything abnormal happens, we can do CT scan. So again, sum up the management: hospital admission, senior review number 2, number 3, further investigations, including all body investigations, please. And one important thing is that she's reluctant to the admission. So you have to convince her. We need to observe him or her since she felt or he felt a bit drowsy or sleepy for a while after the fall. Also, we may consider doing CT scan if anything abnormal happens, or if any strange thing happens or noticed. What are the safety netting? Simply safety netting. If you notice that he is vomiting or she is feeling more drowsy, come back to us. I mean, after sending him home, if you notice any drowsiness or any abnormal sleepiness or any vomiting, come back to us. Usually, the head injury stations are very easy stations. You have only to memorize 2 or 3 things. You have to memorize about the injury, any relevant injury. You have also to memorize about some other important things like what? Like maybe the vomiting, like the sleepiness or drowsiness. These things are very important. Do not ever forget to ask about them. So has anyone got any Dr. Nigar? Number 1, hospital admission. Number 2, senior review. Number 3, symptomatic treatment. Number 4, definitive treatment. Anyone has got any questions so far, guys, regarding this station? I know that head injury can be sometimes challenging for some people. However, they are the easiest station because it's a fixed pattern that you can follow in all the stations. So has anyone got any questions so far? Okay, let's move to the next station. Next station is a little bit challenging, a little bit, is intussusception. And in the intussusception station, you will find a GP letter. What is a GP letter? The GP letter is that the GP letter is that he has referred the baby to you. Why? Because he noticed that the baby has been like having right upper quadrant pain or mass and pulling the leg and bloody stool. So mass, pulling the leg, and bloody stool. This is the GP letter. This is written in the test as well. So before entering the cubicle, you will know that this is intussusception. A very easy station, but just a little bit challenging because why? Because the management. Management, many people miss it. Okay. Why did you take your baby to the GP? Doctor, because he had some tummy discomfort. Tell me more about it, or how you notice it. Because how does a mother notice that the baby is having tummy discomfort? Definitely there is a sign. I mean, the pain is not something noticeable. Pain is something to be like sorry, the pain is not something noticeable. Yes, pain is something to be felt. So you have to ask her, how did you notice that? She will tell you, doctor, I noticed that he has been crying whenever I change the nappy and I touch his tummy. So tell me more about that, please. Like, for example, where was it? She doesn't know anything. She just knows that the pain is like episodic pain in the last 10 hours. And it's getting worse. So has it changed? Yes, it's getting worse. Okay. What about the crying? So now I know that he is crying and he is having tummy discomfort. So I elaborated the tummy discomfort. I have to elaborate the crying as well, right? When did it start? How did it start? Has it been continuous? Doctor, in the beginning it was on and off, but right now it's become continuous. And for how long? He cries for maybe 1 or 2 minutes continuously. Anything else? Yes, doctor. He used to pull the legs toward the chest. And that's how I noticed that as well, that he's having problem in the tummy. So 2 reasons to notice that there is a problem in the tummy: pulling the legs and crying while changing the nappy and touching the tummy. Ask about it. When did it start and has it changed? No. Any other symptom? Yes, doctor. He's passing loose stool. So third symptom, so number 1, tummy discomfort. Number 2, crying. Number 3, pulling the legs. Number 4 is very important, passing loose stool. And here you will get the diagnosis. Elaborate the diarrhea, like for example, since when? Since yesterday. How many episodes? 4 to 5 times. What about the stool? Tell me about the stool. She will tell you, doctor, they are red jelly stool. So now you know that it is jelly material or jelly stool. Red currant jelly stool is diagnostic for intussusception. Red currant jelly stool is diagnostic for intussusception. Okay. So now you'll ask her any other symptom. Yes, doctor, he has been vomiting as well. Due to the constipation, he is vomiting. Okay. He vomited like 2 to 3 times. Green vomitus. You know why green vomitus? Can anyone tell me why green vomitus? Can anyone tell me why green vomitus?
Stomach suction.
Huh?
Stomach suction.
Yes, right. Very good. Bile comes down. When it finds obstruction, it will be expelled in the vomitus. Very good. Okay, so now he has many symptoms: vomiting, abdominal pain or tummy discomfort, pulling the legs, crying, and red jelly current stool. I think this is quite enough to diagnose intussusception. Now he's vomiting and he's having diarrhea. What is the red flag here to ask Dr. Zaid?
Dehydration.
Definitely. You ask, do you notice that his mouth is dry? Is he playful? Is he floppy? Like these things which cause dehydration. I'm going to write you right now how to ask about dehydration. Like dry mouth, number 1. Number 2, floppy. Number 3, lethargic. Playful like before. Okay, able to drink water. Those are the questions to be asked for dehydration. You can even ask 2 or 3 of them, very enough. Any fever? No. So what are your differentials here? I will pick up only 2 or 3 differentials. Number 1, gastroenteritis. Number 2, there's blood. So I will ask about blood disorder. Number 3, any fever or flu-like illness. So let's ask about the differentials here. Did he have any fever or flu-like illness? Yes, doctor. He had chickenpox last month. You know, guys, that intussusception is precipitated by some fever or flu-like illness sometimes. Why? Because these illnesses, sometimes it can cause the baby, for example, these illnesses can infect the bowel itself. The viral infection can infect the bowel and it can cause these things. However, this is not confirmed, but there is a link sometimes between it and the intussusception. What are the other things? So number 1, I asked about chickenpox, fever or flu-like illness. Number 2, any shyness to the light, any rash in the body, any cough, Any discharge from the ear. So again, I have to rule out the cause of the fever, like Dr. Yemi did, meningitis, pneumonia, UTI. Very important. Cause of the fever must be ruled out. This is the second red flag. So the first red flag is dehydration. Second red flag is other causes of fever. What else? Did he hurt himself? No. So, does he have any medical condition like any polyp? No. Why polyp? Because there's a blood in the stool. Any bleeding disorder? No. So polyp and bleeding disorder in the medical conditions. You can also ask about blood thinners, but I mean I'm just picking or just giving you the most important things. Any family history of similar problem? No. Birthday questions, you can ask about them as well. And there is one thing to ask in the feeding. Recent change in the feeding sometimes can affect the bowl, which can cause the interception. So, is he feeding well? What does you feed him? Any recent change in the diet or what you're feeding him? No. So no change in the feeding way. One important question, guys, to ask in any pediatric station apart from the birth. What is the question that I need to ask in all the pediatric stations to rule out one of the most important diseases? Can anyone help? What is the most important question after the birth? I just need one question. Very good, Dr. Bian. Very good. Who looks after him? Very good question, and you must ask it. Okay, now let's find there is no non-accidental injury. Which examination to do here? We need to do the vitals very carefully, and you have to verbalize that I'm looking for signs of dehydration and shock. Signs of dehydration, sorry. And general physical examination as well to look for signs of dehydration, and abdominal examination to look for the mass. The examiner will give you a paper full of findings. He will tell you the child looks pale, peripheries are cold, he is lethargic, the abdomen, there is a mass in the abdomen in the right upper quadrant. He will give you some tachycardia and some tachypnea in the history as well. And hypotension. Definitely he has gone into dehydration. I need to do some investigations. Which investigations, guys? Again, the investigations are routine blood and urine and stool sample and abdominal x-ray. Routine blood and urine and stool sample and abdominal x-ray. Why abdominal x-ray? Because this is suspected to be intestinal obstruction. What are you going to do right now? This is the emergency, right? We need to keep in the hospital, number one. Number two, we need to involve the senior. Okay? Why we need to keep in the hospital? Because we are going to do further investigations. Before these investigations to confirm, we need to give him some painkiller. So number one, we need to do painkiller, give painkiller. Number two, we need to give him fluids, a drip in his blood vessel. Fluids, a drip in his blood vessel. Why? Because of the chance of dehydration. So again, we need to keep in the hospital, inform senior, and we will start the fluids right away, together with the painkillers. This is the most emergency treatment, or the symptomatic treatment that we call. Also, we need to do further investigations to confirm. Which investigations? Ultrasound. Do not forget the ultrasound, please. Do not forget the ultrasound, please. Don't forget to say it at least. What's next? When it's confirmed, we can consider the definitive treatment. What is the definitive treatment in this case? We will give him antibiotics because of chance of infection. We can pass nasogastric tube as well. You know, this is surgery emergency. Remember, guys, I told you 3 in and 3 out. It's surgery. Oxygen, IV fluids, okay, and antibiotics. These are 3 in. What are the 3 out? Urinary output, urinary catheter, nasogastric tube, and cannula. Urinary catheter, nasogastric tube, and cannula. Okay. So we are going to give antibiotics, IV antibiotics mostly, and we are going to start the definitive treatment. What could be the definitive treatment in this case? Okay, most probably the definitive treatment could be air enema. What's air enema? Definitely tearing introduced into the back passage with high pressure of air to reduce this bowel problem, or to push the bowel back again in place. What if it doesn't manage? We can refer him to surgery or operation. So again, definitive treatment is air enema, and it can be attempted 2 more times or multiple times. After which, if it didn't manage, we can refer him to surgery. Which surgery? Simply a cut will be made in the tummy, the bowel loops will be separated and put back again in place. I forgot something. I forgot to tell here in the disclosure it is a condition we call intussusception. What is the intussusception? I need you always to remember this explanation. When some two loops of bowel slide into each other like a telescope. You know the telescope? It always slides into each other. When we open it, we unfold it. And when we close it, we slide it back in place. This is definitely the intussusception. Two loops of bowl slide into each other. That's why we call it, this is why what we call intussusception. Why did it happen? Most probably due to no reason. Sometimes it can be linked to simple infection like the chickenpox. Some other times, or most of the times, it happens due to no reason. Again, the management is hospital admission, senior review, give right now IV fluids and painkillers, and something for the fever if he is ever having. And now start your investigations. What is the most important investigation? Abdominal X-ray and ultrasound is the definitive here. Ultrasound, please do not forget it. After the ultrasound, what you're going to do? You're going to do air enema. What's after the air enema if it fails? Surgical operation. And the surgeon will discuss the operation with them. This is one easy station, but just many questions. The history is long here. Because many findings, abdominal pain, pulling the legs, and the crying, and diarrhea, red currant jelly diarrhea, and vomiting, and nausea, and dehydration, and many DDs, like maybe DDs of the fever, differentials also of the trauma, and some blood disorders. Birth questions, important. Social history, very important. All the examinations. Many examinations and many findings in the examination. So the management is quite short, but the history, and by the way, the good thing is that the presenting complaint for the whole history will be given by the mother. So no need to worry.
Yeah, Dr. Ahmad, you said that the presenting complaint will be given by the mother. So no need to worry, right?
Yeah, don't worry, because you know what? You only worry in one case.
Yeah,
you only worry if you do not ask the open questions.
Okay.
Because
so yeah, on anything else?
Yeah, because if, for example, she told you that there is tummy discomfort and you kept asking, okay, when did it start? How did it start? And after tummy discomfort, does he have, for example, any pain anywhere? Does he have nausea? Keep asking many questions and you reach nothing. So better ask. And by the way, there is a GP letter. So why do you keep asking close the questions and you know that everything is written in the task?
Yeah, because if she told me that he has a crying, there are multiple differential diagnoses for crying.
Yeah, but no, it's not only crying. She will give you also some pulling the legs and some red currant jelly stool, definitely.
Okay, thank you.
Okay, so let's move to the next station, which is I don't know why many people hate it. It is the MMR. The MMR vaccine recently, it doesn't come only as MMR, it comes linked with the autism. So they bring two stations in one station, the autism and MMR. Actually, the autism is only one question here, which is very easy. So this mother is here due. Why? Because she needs to ask about her baby. He is due for the MMR vaccine. She is worried, or she having some concern. What's your concern? She will tell you, doctor, I read an article which says that there is a link between the MMR and the autism. So there must be a link, doctor. I'm really worried. Or she can tell you that her nephew or her friend has 3 years old daughter and she got autism after the MMR. Simply reassure her that there is no link between the autism and the MMR, and this was only one article which was issued on 1998, which said that it has caused autism. And since then, many research studies show that there is no link between them. Sometimes she can be a boring person and she can be annoying, seriously. She can ask you, so why did she get it? Why did my friend daughter get it? Wait guys, 1 minute, wait. Guys, I said 1 minute only, and I'm back. So, she will ask you about the autism here. There is no link. If she's annoying and she asks you, doctor, so why did my friend daughter got it? You can simply ask her what was her age. She will tell you maybe 3 years old or 2 years old. Okay, so simply you can say that usually, the problem is that the MMR vaccine is given at the time in which the autism usually arises. So, for example, if you know that this condition starts arising at 4 years old, and there is a vaccine, another vaccine, a normal vaccine, to be given at 4 years old. This means that some people can link this vaccine to the autism or to the condition, though it just happened by chance. Okay, so simply, this is the thing. Does MMR cause any problem in the gut? She definitely speaks about the enterocolitis. No, it doesn't cause any problem in the gut. What if she keeps silent after asking these two questions? Now you have to explain to her what's MMR. MMR stands for a vaccine given as a single injection, protects against the measles, mumps, and rubella. MMR, measles, mumps, and rubella. How many doses? 2 doses. The first one is 1 year, around 1 year old. The second one is 3 to 5 years old. Why do we give MMR vaccine? Because it protects against these three serious illnesses, the measles, mumps, and rubella, which can cause to some conditions like meningitis or encephalitis, which will happen or which can be very serious or very life-threatening if they ever happen. Are they still present in UK, these diseases? It's very rare in UK. However, some outbreaks can happen at any time. And if they are traveling in any other country in which this condition is endemic, they can catch it. So there are many reasons. So if there is here there are many reasons to give the MMR vaccine. We told her that there can be outbreaks. She can tell you, doctor, but there are some measles cases in the recent years in UK. You will tell her yes, between 2001 and 2013. 2001 and 2013, there have been a rise in the cases of the measles. Sharp rise. But the number of cases fell in 2014 and 2015. And it started to rise back again in 2016. So 2001 and 2013, it's showing a rise. 2001 till 2013. And then dropped 2014 and 15, and that's rising again in 2016 and 2017. Guys, can anyone think why this sharp rise happened? Can anyone guess? Can anyone help me with this thing? Because this will be a very smart answer. Huh?
Yeah, HIV because?
Excuse me, Dr. Zaid, I can't hear you.
Because of the HIV?
No. Dr. Elvira, what's your point? Tell me.
I don't actually remember when this study was published.
1998.
Maybe I'm wrong. Maybe I'm wrong.
No, you're right. You're absolutely right. You're going in the right way. Tell me.
Thank you.
No, keep going. I'm not flattering. Tell me. Tell me.
So means that the study was published that year, and after 3 years, they started to diagnose kids with autism and straight away started to blame the vaccine.
Okay. I will tell you the whole story. Yeah, exactly, Dr. Muniba. This is what happened. You know what? If you follow the UK media, you will find that the woman or the lady, they do not give their children these vaccines after such articles. There have been very big fights against the vaccine in the UK media because of such articles. So, for example, if I come and tell you that this vaccine can give your child maybe epilepsy, and I'm sorry to tell you, but you're not so educated. And you, of course, if you look into the websites, you can find many rumors about each thing. So definitely you will be blinded by this. And you will end up not giving your child this vaccine. And when you do not give them this vaccine, the chance of the MMR will rise. The infection will rise. So I hope you all got it. They do not send their children for the vaccine because of the rumors published about the vaccine. That's why the MMR, that's why the MMR has risen. And this is written, by the way. Okay. So now should ask you, doctor, are there any side effects of the vaccine? You know side effects of the vaccine simply. I will divide it into 3 sections. The first section is within the first week, in which the measles vaccine start to work. Measles vaccine will start to work, it will cause like measles-like rash. Then, second to third week, when the mumps vaccine start to work, it will cause mumps-like swollen gland. And when the rubella vaccine starts to work, about 2 weeks as well, it will cause rubella-like rash. So measles, 1 week. Mumps and rubella, 2 weeks. Mumps will cause swollen glands, and rubella will cause rash. However, if you notice any sudden or like sharp rise in the temperature, come back to the A&E or call the GP, call the doctor. So if she notices any sharp rise in temperature, call the doctor. Is there any alternative to it? No, there is no alternative. Doctor, can I skip it? He can ask you this question. It's advisable not to do that because MMR are highly infectious, and once they happen, they can lead to some serious complications like what we mentioned. Okay? Actually, sometimes she can ask you a few questions. The elder people are eligible to receive it. Yes, no problem if the elder receive further dose or even receive some dose before moving to an endemic area. Sometimes she can ask you, doctor, why do some people who receive the dose of the vaccine will still will still catch measles? Because actually it needs 2 doses to be fully protected. Okay, now you have to ask her some questions to see if the girl or the baby is fit to receive the MMR or not. Which questions? Number 1, how was your health recently? Does she have any fever or flu-like illness? Why? Because you know, in any vaccination, the acute illness can postpone the vaccination, right? Okay. Number 2, any medical condition, any medications? You know, because any immunocompromised patient or any patient or immunosuppressant like steroids or radiotherapy or even chemotherapy, the MMR is contraindicated. Immunocompromised means that you know the MMR vaccine can actually cause infection because the infection is already the immunity is already compromised. So the MMR will actually be vigorous to the body, so it can cause infection. And one important thing, if she tells you, doctor, yes, he's having epilepsy, let's assume that he's having epilepsy. You have to ask about the epilepsy, if it is controlled or not. If the epilepsy is poor control, this is not a contraindication even. This is just like a relative contraindication to postpone the immunization. It's not absolute contraindication, just postpone the medication. It becomes controlled. Okay, number 5, any allergy? If there is allergy to the MMR components, okay, definitely the vaccine is contraindicated. And allergy to the MMR or allergy to neomycin. Why neomycin? Because it's containing actually the same component as the MMR vaccine. Okay, any recent blood transfusion? Blood transfusion in the past 3 months, blood transfusion in the past 3 months is a contraindication. Why? Because you know the blood transfusion will contain immunoglobulins. Okay, the immunoglobulins, what do the immunoglobulins do here? Many immunoglobulins, this can worsen any infection. Like now he's having many immunoglobulins and this is like something like messed up with the immunity. Ask about family history is irrelevant. Then ask about the birthday questions. Birthday questions as well are irrelevant, but you can ask about them to gain marks in your data gathering. So this is the station so far. So the main concern, I mean, once you address the autism, you are on the safe side. Well, I'm sorry, Dr. Elvira, one friend of mine, educated lady, still didn't allow her 3 kids to be vaccinated. People, I know some other lady as well. She's very educated and I mean, she's working like in the bank, and she still does not believe that it is useful. Wait, guys, give me 1 minute. Okay, next station is the pyloric stenosis. And by the way, I have one story in the pyloric stenosis. I got it in my final year exam, and thank God I messed it up. It's not a station, it was just like sort of for exam, sort of like OSCE case, and I messed it up. And that's why I got it in my first attempt and I scored 11 in it. So this station is quite easy station. The lady is very nice. The mother is very nice. And just she needs reassurance. All the time she needs reassurance. How can I help you? You know, guys, the presentation. Let me point out the task because here the task was a little bit significant. Wait for a minute. I'm just trying to pull it. Your FY2 working in pediatrics. The patient is 6 weeks old baby. Brought because of vomiting. The vitals have been recorded. You know, in the vitals, what you expect in the vitals, Dr. Muniba? I see that you are quite active today, Dr. Muniba. So tell me what you expect in the vitals of the pyloric stenosis.
The patient would have low blood pressure
Thank you.
and increased respiratory rate, tachypnea and tachycardia.
Increased respiratory rate, tachypnea, and
Tachycardia.
and tachycardia. Can't you think about anything else? 1 pound.
Sorry?
Please. Can't you think about anything else?
The temperature doesn't need to be necessarily high in it.
No,
But
I'm not speaking about the temperature. I was speaking in general. Can't you think about anything in the findings, like general findings? Like
the child would be
doing
dehydrated.
the, okay, what else?
I don't know.
Okay, so Dr. Muniba, when someone is having too much vomiting as well, they tend to lose many minerals, right?
Yes, metabolic alkalosis.
Yeah, bravo.
Well, that doesn't come in the vitals.
No, yes, I told you anything else. I kept asking anything else in the findings.
Okay, sorry.
No.
Of course, metabolic alkalosis.
Yeah, okay. So here simply this station, he will give you the vitals. The vitals will show tachycardia and tachypnea, and sometimes hypotension, but not all of the times. So she will tell you, doctor, I went to the GP, or sorry, I came here because my child has been having vomiting. Elaborate the vomiting. He's having vomiting maybe since 2 days, and right now it increased. Okay, two questions not to miss here. For example, you know, vomiting in 6 weeks old. What is the most common cause of vomiting in 6 weeks old? Definitely pyloric stenosis. So I need to ask two questions in the elaboration of the vomiting. How long does it take for the baby to feed and to vomit after the feed? And can you describe the vomiting? Those two questions will confirm the diagnosis to you. She will tell you, doctor, he vomits right after the feeding, right away, like after a few minutes. And the vomiting looks like a fountain, it's projectile. What is the content? The content is the milk, undigested milk. You know why? The milk barely goes down to the stomach and it will be expelled out of the stomach. Because there is like narrow outlet of the stomach. So the milk will never go beyond the stomach. So it will be expelled from the stomach. So it will be undigested milk. Is it digested or undigested? Definitely, it will tell you undigested. No blood. So again, can you describe it? And how long does it take him to vomit after the feeding? And what is the content? Anything else? Like what, doctor? Now you know that he will definitely be hungry after the vomiting. Why? Because whichever he fed, whichever he took, he threw it up. So doctor, he looks hungry. Someone who's looking always hungry and vomiting too much. What is the red flag here, Dr. Muniba?
The baby can go into shock, hypovolemic shock.
Hypovolemic shock is mostly with some bleeding, right? But if there is vomiting or too much diarrhea, what is the most important red flag?
Basically, the patient would be dehydrated,
Yeah,
drowsy.
exactly. Those are the red flags here.
Yes.
Okay. So, Dr. Muniba, you know, so now you know that dehydration is one of the reason for the hospital admission here, right?
Yes.
This is the most common, or this is the most important thing for the hospital admission, besides the definitive treatment as well.
Yes, exactly.
Okay. Okay.
Yes.
I need you to ask me two more questions here. We asked about the dehydration. Which dehydration or which signs of dehydration?
We can ask, is the baby playful like before?
Okay. What else?
And floppy. Is the child floppy?
Yeah, exactly.
Is he dehydrated?
Yeah, exactly. Uh-huh. You will ask him if she.
And sorry, drowsy. I wanted to say drowsy.
Thank you, Dr. Muniba, for this medical nice elaboration. Mr. Muniba, I'm kidding, okay? Do not take it seriously.
No, it's okay, it's okay.
Okay, I know it's okay anyway. So, Dr. Muniba, one more thing. When you ask me, when you finish the dehydration, because this is the most serious, what is the next question?
Now, we can ask anything else.
Anything else?
Yes, or are we done with it?
This is a very good question. You know why? Because she will tell you, doctor, yes, I noticed that he is not passing stool. When was the last time he passed stool? You know, 2 days ago. So you have now two symptoms, vomiting and projectile vomiting. Sorry, projectile vomiting and dehydration and not passing stool. Right?
Oh, yes. Yes.
Aren't these enough to diagnose pyloric stenosis, Dr. Muniba?
Yes. I guess they're enough.
Okay, very good. This can be enough. So, what are your differentials here, Dr. Muniba?
My differentials would be number one, the pyloric stenosis. These symptoms can also come in intestinal obstruction.
Not really.
Like because
It's fine. It's
subacute.
okay.
Maybe.
Yeah, it's fine. Okay, keep going. What else?
And infection, gastroenteritis.
Perfect. Infection most common. This is the most relevant right now.
Okay.
What else? Concentrate.
I can't think of any.
Okay. So, gastroenteritis is the most important thing, actually. Okay. You can also ask about any mass or any bowel problem, any other bowel problem. You did not ask about any other any diarrhea. Okay, Dr.
But you
Elvira.
said, yeah.
Dr. Elvira is fine. Take your time. So you didn't ask about constipation. You have also to ask about any episodes of constipation in the beginning or in the middle.
Oh, okay.
Okay.
All right.
Now you will ask about the family history and the birth questions. Irrelevant here. Okay. Let's move to the examination, Dr. Muniba. You are with me on the stage so far. Which examination to do, Dr. Muniba?
We would do the vitals, journal examination, tummy examination.
Okay.
We can also do we do PR examination?
Not really, but tummy is fine. You know what you find in the tummy? You can find a mass in the tummy, in the right upper quadrant.
Yes. Olive-like mass.
Exactly. You know how to demonstrate this mass? It will be definitely more visible after the feeding. So I will do one test we call test feeding or feeding test.
Yes, when we ask the mother to feed the child and we check it after
Exactly.
5-10 minutes.
Exactly, perfect. Dr. Muniba, we said about the vitals. Which investigations we are going to do?
Now we will do routine bloods, urine test. We can also do ABGs to check for metabolic alkalosis.
Uploads, seriously, uploads. I need to hear EBG. Why? Because there is metabolic alkalosis. Okay, so what is the management? Disclose to me, Dr. Muniba.
From what we have assessed about your child, it seems that there is a problem in his gut.
What's the problem, doctor?
Basically, at the lower end of the stomach, there is some obstruction.
Problem,
and
doctor?
Which is called pyloric stenosis.
Yeah, thank you. Take 1 mark for diagnosis, doctor, please. What is this, doctor?
Stenosis is called the narrowing, and pylorus is the lower end of the stomach. So when there is narrowing or blockage at that end, it is called pyloric stenosis.
Oh, doctor, why did this happen?
It could be, why did this happen? It could be because of, it doesn't need to be any, it can be just idiopathic.
Idiopathic. You will tell the patient idiopathic?
No. I'm saying that it doesn't need to be any cause.
Actually, you are not talking to a doctor. Just say the cause is unknown.
The cause is unknown.
Do not use any medical jargon. If anyone is using medical jargon, they are pissing me off. I mean myself. It took me 2 years in the medical school to realize the word idiopathic. All
right. The cause is unknown. Usually.
The cause is unknown. Okay? So what are you going to do, doctor?
Well, we're going to keep your child in the hospital
Why?
because as he's been vomiting for so long and he has very less fluid in his body. So we need to keep him in the hospital. We're going to run some tests and we're going to give him some fluids
Why fluid?
through his blood vessel since he's not taking any milk.
Hmm.
That's why.
So you're going to give him fluid since he's not taking milk.
Yeah, and the body, he's not taking any food at all, basically.
Yeah,
That's why
because
we
he's
need to.
dehydrated.
He's dehydrated.
Yeah, right?
Yes.
Dr. Muniba, so what are you going to do now after this? I mean, what's next?
We're going to run further investigations.
Which investigation, doctor?
Ultrasound of his tummy.
Perfect. The ultrasound is confirmatory together with the palpation, the test feed test. The test feed is the test in which we ask or we give him milk and we feel the stomach or we feel the epigastric region right after the feeding. You will find the bulge, the mass. The pyloric stenosis or the pylorus will bulge at this point. Dr.
Yes.
Muniba, how are you going to treat it?
Well, it's the definitive treatment is surgery.
Oh, surgery? How are you going to do it, doctor?
We're going to before the surgery, we're going to put your child into sleep,
Okay.
and you can accompany your child while we giving him the sleeping medication.
Okay.
After that, we're going to make a cut on his tummy,
Yeah.
and from there we can open up the stomach and reduce the narrowing area.
Doctor, but I've heard that it can be done in a keyhole.
Is it? Oh, yes, it can be done as a keyhole procedure as well.
Mm-hmm. Doctor, before doing the surgery, don't you need to do anything? I told you before, we need always to empty. Why we empty the field? If it's bowel problem, we need to empty the bowel. If it is stomach problem, we need to pull nasogastric tube. Because why? To clear the field before the operation. Because as a surgeon, inshallah, Dr. Muniba, when you become a surgeon in UK, you do not want to open the tummy and find many milk pouring in your face.
Okay, but the child
Right?
is already not eating anything.
Yeah, I know, but I know just to clear the field.
Okay.
To clear the field, you need to do what? You need to
We
clear it by
put
putting.
we're going to put a tube through his nose into the gullet to clear the milk or fluid, whatever in the stomach, to make the area clear before surgery.
Perfect. And now you can do it as you will give general anesthesia, and you can do the keyhole surgery. What is the keyhole surgery? The cut is made in the pylorus. You know how? Simply, let me tell you something. Actually, this needs drawing. This may need drawing. This may need drawing.
Yes.
Simply, the pylorus is inflamed or thickened. You're just going to make small cut in the pylorus. Why? To widen the pathway. That's it. This is the whole operation. Is he going to be all right, doctor? Okay, after surgery, they will start feeding gradually. This is the whole station. Thank you, Dr. Muniba, for your cooperation. This was almost perfect.
Thank you.
Okay, so next station is a medical error. Medical error, which is penicillin allergy. Okay, in the penicillin allergy station, the mother is very angry. So, Dr. Bina, tell me, you know the mother is very angry. What is the first thing you will do in this station? I mean, you will enter right now the cubicle, and you're now greeting yourself to her, or even before greeting yourself to her. What will you consider here? Tell me, Dr. Muniba, Dr. Bina, sorry. Dr. Bina, okay, Dr. Bina. Okay.
Hello, 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 hello.
Yes.
Sorry.
Tell me, Dr. Bina, I know she's very angry mother. I need you to tell me quickly. What are you going to do when you enter the cubicle? I need to speak to one of you.
I'm here to address all your concerns.
Yeah, exactly.
So,
but will you consider shaking hands with her?
no, because she's angry.
She will tell you down and you will feel very embarrassed.
Okay.
So now I'm going to talk to you and address all your concerns. Okay, now her concern is that her baby or her daughter has developed rash because she was prescribed some antibiotic. Okay, ask a few questions. Number one, may I know which drug she has been prescribed? She will tell you amoxicillin. How many doses she had? 2 doses. So she had prescribed amoxicillin and she received 2 doses of it. I told you in any concern or any ethics, you have to ask number one, the reason for visit, number two, the current condition, number three, PMH, number four, here pediatrics, bird questions. Okay. Why did she come to the hospital? She had sore throat and flu. Now ask when did it start and how did it start? What were the symptoms? She had some cough, she had some shortage of breath, or she had some like a sore throat. That's it. This is the presenting complaint which she came with like 2 days ago. And how is she feeling right now? How is she feeling right now? She is the same. Why she is the same? Because she stopped the medication. The mother has stopped the medication after she noticed the rash. So definitely the daughter did not improve. What are the red flags? You know that this condition has been there since 2 days and the medication is stopped, which means that the chances of developing complication is high. So which complications to ask here, Dr. Bina, and please do not mute yourself till I tell you today. Tell me quickly, which complications?
Any shortness of breath.
Pneumonia.
Pneumonia, yeah.
What is the other red flag?
Meningitis.
Perfect. So I have to ask about these two things, right?
Yes.
Okay. Now you asked about the condition, the current condition. Ask also about the rash, because this is part of the current condition or part of the presenting complaint. How to elaborate the rash, Dr. Bina? When did you notice it? Or where is the rash?
Yes.
Where is the rash? When it started? About its color, itchy, like these things. Okay, now you asked about number one, the current condition, or number one, the reason of visit. Number two, current condition, including the rash, which is still present. Number three, I also need you to mark one more thing. You have to ask about other symptoms of anaphylaxis, because usually this could be anaphylaxis. Anaphylaxis is not only presenting with rash. So what are the other symptoms of anaphylaxis? Number one.
Again, shortness of breath,
wheeze,
swelling.
Yes, swelling in lips.
Wheeze, yes.
Were you sleeping, Dr. Bina?
No.
You were.
Hello.
Okay. Yes, hello, can you hear me?
Yes, yes.
Okay, now move to the past medical history, Dr. Bina.
Okay.
Which is the first question in the past medical history? Has this ever happened before?
Has it happened before?
Yes, doctor, it happened twice before, or once before, when she was prescribed amoxicillin.
Okay.
And why
May I
she
know when was it?
Yes, when was that? A few years ago, and she was prescribed
Okay.
for ear infection.
Okay.
And what did you do then? I told the GP, and the GP told me that she has allergy to amoxicillin, and he stopped it and he changed it to something else. Okay, and what happened this time? Did the doctor ask you about the allergy this time? No, doctor, no one asked me. And that's why I'm here. I need to know. What will you say right now?
Did you by any chance tell the doctor that?
Okay, perfect. I did not tell him. But actually, by the way, very important to apologize to her.
Yes, of course.
Apologize. I'm so sorry. That should have been asked by my colleague. I will definitely talk to him to find what happened. But by any chance, have you told him about that? No, doctor. I was under stress and I forgot. No problem. Anyway, you did the good job, or you did the right thing by bringing here to tell us about her allergy. Okay. Now you asked about the previous episodes. The last questions or the remaining questions are not important. I mean, you can ask about the family history, the medical conditions, and such things, and bird questions. Do examination. What is the most important examination to be done here? Number one, ENT, because she's having sore throat. Number 2, respiratory examination, Dr. Bina.
Yes.
Number 3, as well, one more examination. You know what more examination?
Examination of the rash.
Perfect. The examiner will show you the rash, or the mom will show you a rash, and all the examinations are normal.
Okay.
What's wrong, doctor?
Well, your child actually developed as a side effect because of the allergic reaction because of the medication that he was given.
So it is a drug reaction, doctor?
I'm afraid it is.
Oh my God, doctor, is it serious?
But I'm really sorry about what happened, and I can understand that you're really worried. But you did a good thing by stopping the medication. It could have been a serious reaction.
Thank
but,
you. What are you going to do right
since
now,
the
doctor?
child is fine.
What are you going to do now?
Okay. I'm going to talk to my senior, and we need to stop your medication, and we can start another one.
Which medication?
The child still needs medication. We can give erythromycin.
You will give it from your head, or you will open the BNF, Dr. Bina?
BNF.
Your name is Bina. You should not forget about the BNF. Bina, BNF.
Okay.
BNF. Always remember this.
Okay.
Okay. What's your next step, Dr. Bina?
So I'll refer to my book and I'll look up for the
Okay.
medication.
Thank you. What about after?
Oh yes, and I'll report this and I'll like that the child is allergic in my medical notes, so that it doesn't happen again.
In your medical.
In the record, in the medical record.
No, it's fine. It's fine. It's absolutely fine. Just say whatever.
Yeah.
Say whatever. What else?
And,
so number 1, you will document it, right?
Yes.
Very good. So you stopped it and you will document it, right?
Yes.
What else? What about the rash?
Oh, and because it's itchy, I'm going to give you some medication, anti-allergic medication.
Okay. The rash, what about the rash? Yes, antihistamine. So antihistamine will resolve it.
Yes.
Okay.
Hopefully.
Usually it will resolve
if it doesn't get resolved,
wait.
come back to us. Sorry.
It will resolve on its own. However, we'll also give her antihistamine. Doctor, should we keep her in the hospital?
Since your child is doing fine and there are no serious reaction to it, there's no need to keep in the hospital. Or I don't think there's any need.
You're right. You're right. We stopped the medication and we identified the cause, and she's absolutely fine right now. Doctor, will it happen again?
Yes, it can happen again. So therefore, it's necessary to inform the doctor that the child is allergic to the medication. So the child doesn't receive this medication again.
Doctor, how can you make sure that this doesn't happen in the hospital?
The incident form.
Perfect. What if she's still not satisfied?
PALS.
Perfect. Thank you so much, Dr. Bina. This was awesome. Seriously. Just apart from that, you forgot to open the BNF. It was awesome.
Thank you.
Okay.
Can I mute now?
Huh?
Can I mute myself?
Yeah, you can mute yourself.
Okay.
I'm sorry to interrupt your silence.
No, sorry.
Okay. One thing here, guys. This station actually it came to mind today, but with a twist. The twist right now is that it started coming on in January, and the twist here is that she stopped the medication. Sorry, she know that the child is allergic to penicillin, and she told the nurse. She noticed in the prescription that it's written penicillin, so she went to the nurse, and she told her that the child is having amoxicillin allergy or penicillin allergy. But after a while, she noticed that the nurse was still giving the penicillin to the child. That's why she got upset and she wants to talk to you. The task here will tell you that the doctor prescribed it to the child. The mother told the nurse, but the mother noticed that the nurse was still giving it to him, the penicillin. So here she will ask you two different questions. I told the nurse, why did she give the medication? Despite I told her that he's having allergy. Why did she give the medication? Now you will tell her, I'm really sorry, but you will keep apologizing in this station, but you reassure her that usually the nurses follow the prescription written by the doctor. That's why sometimes they are not the one who make decision. However, this is not an excuse, and I will talk to my nurse colleague to find out what happened. So you will keep apologizing here. What is the other thing? Here in this case, any allergy case, number one, stop the medication. Number two, document in the findings or in the record. Number three, inform senior. Number four, do an incident form. Number five, if she is still unhappy, guide about pulse. Two more advices. You can provide with bracelet, which shows that is having penicillin or amoxicillin allergy, and you also will tell her about the epinephrine pen. The epinephrine pen is sort of adrenaline or epinephrine, which to be given in case of any acute allergy or anaphylaxis. So in this station or in the twist, you will take similar history. You will take everything. You will ask about everything. Please do not forget to examine. And in the management, you will change the medication. How will you change the medication? You will open the BNF and you will say that after discussing with your senior, we'll prescribe another medication we call clarithromycin. You will have time to open the BNF. You must open the BNF here. Okay? To be a safe doctor. Okay. So this is a station with S twist. It came to my day, by the way. The lady is very angry, and she's really angry. She's very, very angry. You cannot imagine. She's wearing black. I can remember she was wearing black, and she didn't give you the chance to talk about anything. Now another medical error. Foreign body, but a telephone call. In the telephone call, we agree that you start your call by, I'm Dr. XX from this hospital. Can I confirm your date of birth? And I'm talking to, for example, Jenny mother. Yes. Can I confirm Jenny date of birth and address? Yes. And telephone number as well. You can confirm it. The examiner will tell you, assume doctor. Right now, you're going to start. How will you start the station? You will tell her, she will tell you, doctor, I remember that you were the one who saw, I remember that you are from the hospital which we brought Jane yesterday. Yes, doctor. So yes, sorry. So can we go again through what happened? She will tell you, yes, doctor. You know, she was playing with her little brother, and suddenly this morning, doctor, I went in the other room. I heard her choking. What did you do after that? I went, and when I saw her breathless, you know, I quickly looked into her mouth, and there was nothing to see if there is any block. What about after that? I brought her here to the hospital. Immediately. You did the right thing by bringing her here. You know, this station, actually, the task here will say that there was a foreign body detected in the esophagus. But you did not spot it on the x-ray. So you sent her home. So here you know that there is a foreign body in the esophagus, which he did not spot. And you are talking to the mother right now to disclose this to her. Okay. Now you ask about the reason of the visit. Number two, how is she right now? Which question to ask? You know there is a foreign body in the esophagus. So you need to ask her, is she coughing? Does she have any breathing problem? These are the respiratory symptoms of the esophagus. Number two, does she have any vomiting or any distension? No. Did she pass any stool? So I asked about the bowel problem and the stomach problem and the respiratory problem, which can be related to foreign body in the esophagus. Now disclose the medical error that we received the report from the radiology department. We realize that there is a button in the food pipe. That's why I'm calling you now. Now comes the problem. You keep apologizing all the time, and you will tell her in the end. But the good thing is that the radiology doctor, who is expert in this, reviewed it and reported the X-ray. Unfortunately, they were able to spot the button in your baby's food pipe. So what are you going to do right now? We need to bring her back to the hospital. No, I want to bring her back. May I know why? Doctor, because I'm having the rants. I'm having whatever. But this is important for her. Doctor, but I can't come back. Now you can send an ambulance to bring her. Why ambulance here? Because this is an emergency. So you can send an ambulance to her. Doctor, but shall I come with her? I'm on zero contract. Whatever, she will tell you whatever. Tell her simply you can't talk to the people in your work. They will definitely understand it. Doctor, but why you need her back in the hospital? Because we need to assess her again. We need to see her again. Okay, now she will accept coming back to the hospital. You have also to ask her about the foreign body. Why? Because it's important, if it's metal or something. So ask her what was around Amy when she was choking. By any chance, could it be battery? No, it's not battery. Take some medical history as well, like for example, medical condition, medications, allergy. What is the management here? Number one, you will do when she brings her back to the hospital, you will do metal detector tests. Okay, metal detector tests very important to see if this is a metal. Number two, we may repeat the X-ray as well, and we may do CT scan. Okay, what if there are many possibilities, or two possibilities. If the button has passed through the junction between the esophagus and the stomach, the cardia, if it has passed down to the stomach, this means that it has passed the narrowest part of the gut. So it's more likely to pass in the stool. So we will only follow her up for 24 hours. What if the button, if it did not pass yet? We may need to repeat the investigations again to see the button. If the button did not pass yet, we may need to do endoscopy. Why endoscopy? Either to take the foreign body away or to pull it down to the stomach. Okay. What is the endoscopy? Camera test. She is not happy yet. You will do instant form. Still insisting pulse. This is the most important thing. If she is ever found to be normal and the foreign body past the esophagus, it will give her some warning signs. The warning signs of the intestinal obstruction, like if you notice any crying, any tummy extension, if no passing stool, come back to the hospital. This is the whole station. And we are sorry guys, I'm finishing the session right now. Tomorrow, our appointment will be, or our meeting will be at 3:30, 4:30. We will start half an hour ahead. 4:30. I will announce it in the group right now. 4:30 tomorrow, we will discuss the remaining pediatrics and the SIMMAN station. For that, I'm going to repost the SIMMAN recordings right now. I need all of you to go through them. Why? Because tomorrow I will only practice 3 or 4 of them with you. I will pick up 3 people to practice some of the SIMMAN only to familiarize you with the approach. And you listen to the recordings very carefully. Listen to them very carefully again. Those are the recordings which happen in the cubicle. Listen to them, and we're going tomorrow to practice selectively 2 or 3 of the SIMMAN, or even 4 of the SIMMAN station. Okay? So, thank you guys for listening today. And tomorrow we'll start half an hour earlier. It can be a longer session as well tomorrow. So have a good night's sleep and see you inshallah tomorrow.